going to be a co-host.
Okay, I'll make her a co-host when she arrives. And there's Will.
Mary Brosnan, is that from CB5? I guess
Mary Brosnan is from CB5. Hi, Mary.
Hey, Renee.
So the recording has started, is that right, Mark? Hi, everyone, and to those members of the public who are attending, welcome to this meeting. We're going to start in a few minutes. We're going to give some time for people to join, and then we'll take you through how everything is going to go tonight. So bear with us a little bit longer. We're waiting for our committee members to join, and why don't my participants show up? Oh, here we go. So now, here we go. Hi, Carlina, welcome. We have a handful of elected officials who are doing us the honor of attending tonight. So we're going to get to you guys before we delve into the meat, the meat of the conversation. It will be a few minutes. So if you feel like you want to turn your camera off, no one's going to be offended.
All right, I appreciate that. I'm here.
I'm sure you got a lot going on, so
no, it's okay. If you see me leave, you know why. Baby crying.
Yes, absolutely.
I'm really just honored to be here. I
Great.
really appreciate this conversation.
Ritu, you're going to be a co-host with me, and we're just going to give it a couple more minutes for everyone to join.
Right, I was going to say while we're just here that I saw little Benny last night when at VID, and he is so cute, Carlina. You've done very well.
Thank you. And how good was Jamie holding him?
How was he? He looked very, how was he holding him? He was holding him in his arm. What's the question? Oh, look, we got Brad's daughter too.
Excellent.
Very good. Very cute.
Hi, Brad. Thanks for joining us tonight. I think you may already know, we're going to get to you guys all before we delve into, we're going to start with some introductions and sort of run a show, and we'll get to you guys before we delve into their full conversation. So just bear with us. And as I said to Carlina, if you want to turn your camera off, no one's going to be offended. And we know that you're here. And Eric is here, same thing. Hi, Eric. Thank you for your guidance on this subject.
Yes.
And let me just see if Renee, you want to check out your committee? I see I have 2.
I see 8.
Rachel, I see Ritu, I see Will and Wayne. I think we're pretty much here because and Ivy's here. I haven't heard from John Paul, and I know that Ryder's out. So do you want to, Maria has not yet joined us. Maria Ortiz of CB4 is racing home, probably in a panic. But I am wondering if maybe we want to, we'll give her a minute and then we'll just jump in, and if she comes later, that's fine.
Good idea.
And and Maria is here. Okay, I think that's Maria. Maybe not. I'm on. I don't know who that was, but maybe it's Maria.
That was me, Ritu.
Ritu. Hi, Ritu.
Hi.
And your phone number doesn't show up as your name. And Maria is here too. Hi, everybody. Maria, thank you. Take a deep breath. We're all good. It's 6:34. We're going to start the meeting. I see that we have 28 attendees and at the moment 25 panelists. That's a lot of panelists. Welcome, everybody. My name is Susanna Aaron. I am the chair of the Human Services Committee for Community Board 2, which is generally Greenwich Village, Soho, NoHo, 14th to Canal Street. We have organized this meeting with community boards 4 and 5. And for Community Board 5, which is Midtown, and us, it is actually our monthly meeting. We also have the support from CBs 1, 3, and 6, which means that we now have, and they've each sent some representatives from their community board to attend the meeting, which means we have representatives from all of the community boards south of 59th Street, which is really quite a big showing. It's a lot of people. We wanted to first thank our district managers because they're making it possible for us to do this. There are some logistical hurdles that they helped us through. Mark Diller at CB2, Jesse Bodine at CB4, and Marisa Mack at CB5. I also want to thank in advance Ritu Chatri from my committee, who's going to help us with logistics and keeping everyone, keeping this meeting flowing. And I wanted also to thank in advance everyone who shared their expertise with us getting ready and becoming more informed on this topic as we got here. And of course, thanks to all of the attendees who are here and joining us in this conversation. We have a lot of people. We hope to do a good job running the meeting. It's an unwieldy, it's larger than I've actually ever hosted, but I think it will be fun. So thank you in advance for your patience as we wend our way through this. The agenda topic for tonight is this: what programs can city and state implement on a short timeline for those suffering serious mental illness in our communities? Serious mental illness, also known as severe mental illness, it gets an acronym, which is SMI. You're going to hear that a lot tonight. I'm going to start with very brief introductions of my committee. I'll call on you guys and you just say your name. Let's start with, I see Will.
Hi, everybody. Will Benish, CB2 member.
Keen.
Keenberger, CB2.
Rachel.
CB2 public member, Rachel Yarmolinsky.
Yarmolinsky. Ritu.
Hi, Ritu Chatri, CB2 member.
Wayne.
Hi, Wayne Kwadler, CB2 member, and thank you, Susanna, for organizing this whole thing.
And I also see our community board chair, Susan Kent, and one of our board members, Carter Booth. So now let's go to Renee and CB5.
Thank you, Susanna. Good evening. Thank you all for joining this evening. Really appreciate it. My name is Renee Kinsella. I'm the chair of the Budget, Education, and City Services Committee of CB5. Community Board 5 runs roughly from 14th Street up to 59th Street, from Lex to 8, essentially the very heart of Manhattan. One of the things that we've noticed in our district, and I believe is true of many of the areas, including CB4 and 2, is that there's been an increase of individuals living on our streets, many of them perhaps suffering with serious mental illness, and they seem to be really struggling and in pain. And our purpose is really to, one, establish there is a need for services in our community districts, and two, if that's the case, then determine what City Council could possibly fund this year and even New York State government next year to address these needs. As Susanna did, I'm going to introduce the members of my committee, if they could just say hello. Seth Borden.
Hi, everyone. Yeah, I'm Seth Borden from CB5.
Mary Brosnahan.
Hi, Mary Brosnahan, CB5.
Jonathan Stello.
Hi, John Cedillo from CB5.
Laura Garcia.
Hello, I'm Laura Garcia, CB5.
Tristan Haas.
Hey, everyone. Tristan Haas. Happy to be here.
Mark Hirschberg.
Hi, I'm Mark Hirschberg, also from CB5.
I don't see Bridget. Bridget, are you here? I don't see you. Joe's Mafia. Joe, I see you, but you're muted. You're still muted. We have Joe Mafia in the house. Pete Webb.
Hi, Pete Webb, Community Board 5.
Rob Isaacs.
Hi, Rob Isaacs, Community Board 5.
And Zona Yu.
Zona Zoo, great seeing everyone.
And I'm going to hand this over to Maria.
Thanks, Renee. Good evening, everyone. My name is Maria Ortiz. I am co-chair of Housing and Health and Human Services at Community Board 4. I am a New York State licensed social worker. I was born and raised in CB4. I currently work in CB4. CB4 covers Chelsea, Hudson Yards, and Hell's Kitchen. CB4 essentially is from about 59th Street to 14th Street, 8th Avenue or 6th Avenue to the Hudson River. I'm grateful to be here this evening. I'm grateful to see all of you here this evening. This is not a community board meeting for CB4. However, I believe we might have some folks from CB4 here. I'm not sure if the chair of CB4 is currently on, Jeffrey LaFrancois or Jessica Chates, the first vice chair. However, I know if they're not here right now, they're expected to be here. A reminder for all the attendees, the chat function will not be monitored. So please save your comments or questions for the public comment section. Again, the chat function is not going to be monitored. So please save your comments or your questions for the public comment section. I look forward to us coming to a resolution tonight, which we can support, that can be implemented on a short timeline. Renee?
Sure. There are a lot of us here tonight, and so here's how we're going to conduct the meeting. I know this seems like a panel presentation, but it's actually the monthly meeting for two committees, the Human Services Committee of CB2 and the Budget Education City Services of CB5. The goal is that each committee at the end of this meeting will adopt a resolution that's going to support a short timeline solution. The resolution will obviously come from what we've learned at tonight's meeting from our experts and the public. And the resolution will then be shared with the other community boards attending tonight, so they may also support these short timeline solutions. Out of respect for our panelists and their limited time, they're here with us only until 8:30. We hope to conclude the public session by 8:30. Here's our process. The three of us, Susanna, Marie, and myself, are going to moderate a discussion with our experts who will discuss what they believe are short timeline solutions to SMI. We're then going to take questions from the committee members of CB2 and CB5 and CB4. And then we're going to ask committee members of CB1, 3, and 6 if they have any questions. Finally, we're going to take questions and comments from the public. You'll have 2 minutes to make your remarks, and we'll use a timer. So please make your key points up front so we can hear them before the time is up. Once we've addressed all of the public questions and comments, we're going to turn to business session. And at that time, CB2 and 5 will individually enter into business session where we would determine the substance of our resolution. Everyone's welcome to listen in, but we don't entertain public input at that point. I know that I threw a lot of information just now. Don't worry, we're going to take you through step by step. But right now, a few of our electeds are with us here tonight. So we will first invite them to greet us and say a few words. Susanna?
I just wanted to start with Eric Botcher, City Council member. Eric, you're here. Do you want to unmute yourself and speak?
I'm going to yield to Councilmember Rivera or Senator Hoylman, who are here way before I was.
Okay, great. And Ritu, will you run the timer? And thank you guys, by the way. And I hate to put you on a timer, but you're being very kind given the time constraints that we have.
Just a little clarification. I'm not going to put the timer up on the screen. I will let you know when you have 30 seconds left remaining, and you'll be given 2 minutes for your comments on everyone.
So we'll start with Brad.
I'm going to defer to Councilmember Rivera since she was here first.
Oh my gosh, okay. Carly.
All right, I appreciate that. We're always striving to be more punctual as elected officials. Okay. And I want to just thank the two of them, Eric Botcher and Brad. Eric and Brad, you've been tremendous allies in this. And thank you for all your support during my leave as well. And for the gift, Brad, you're amazing. All right. Good evening, everyone. I just want to thank you for convening the meeting. I'm Council Member Carlina Rivera. I represent District 2 on the east side. I just want to start by saying clearly disinvestment and underinvestment in our mental health care system has created a situation where too many New Yorkers in need of mental health care are unhoused, they're unemployed or underemployed, and they're involved with the criminal legal system. So there are persistent structural issues that perpetuate these inequities in the healthcare system. And today, what I'll do is to help, I hope with your resolution, is mention a few things that we're advocating for in the city and within the council, especially as we approach the budget deadline in June. And I'm sure Brad will talk a little bit about what's going on at the state. So we all know that New Yorkers, especially those who are historically marginalized, they're the most vulnerable and they're less likely to be connected with the care that they need. This has led to significant concerns about our quality of life, about our public safety, and of course, the well-being of everyone in our community. And so city health officials recently reported that nearly 1 in every 25 New Yorkers live with a serious mental illness, with around 280,000 adults dealing with diagnoses like major depressive disorder or even schizophrenia. Yet New York City only has about 1,000 state psychiatric beds for people in need. So that's one thing that we're advocating for, is more psychiatric beds spread equitably across hospitals in the city and in the state. And according to Coalition for the Homeless, of the nearly 94,000 adults eligible in December 2021 to receive enhanced mental health services in New York City under the state's Medicare Managed Care program for those with serious mental illness, only about 2,100, that's a meager 2.3%, actually received such care in the prior 12 months. And that's not even, I could talk just 30 seconds on 50% of individuals incarcerated on Rikers Island have a mental health diagnosis, and it is 80% for the incarcerated women and gender expansive people that are there. So I'm sure Councilmember Baccio. Okay, got it. We'll talk about the mental health roadmap that the council just put out, that I was proud to co-introduce and be a co-prime with Baccio. I'll let him get into that. But some of the things I think that could be helpful in terms of how we can advocate is, we just stood with the Manhattan District Attorney, $9 million criminal justice investment initiative to reach New Yorkers with deeply entrenched needs. We're advocating for a $50 million investment in Bellevue in their comprehensive psychiatric emergency program. And of all the mental health service programs that we invested in the city, I'm going to drop a link into the chat that's going to show all the programs that we fund every fiscal year. And we would love help advocating for expanding that programming, since the mayor has the majority of the money in the city. Okay. So with that, I know that was kind of a lot of info. I want you to know, if you ever need anything, clearly you can reach out to my office individually, but we need access to psychiatric beds and services. I'll put that information in the chat. Thank you for the time, and thank you for bringing us together so we can talk this through together and find some solutions.
Thank you, Councilmember Rivera. That was great. That was a lot of information. Okay, since you guys have decided that you want to go in the order in which you showed up at the meeting, I think the next person is Senator Brad Hoylman-Siegel.
Thank you, Susanna. I was not in a knife fight. I went to the dermatologist today. So just FYI.
You're a very small child on the screen. You can be grateful.
Okay, good. Good to see Councilmember Rivera and Baccio. And thanks to the City Council for their efforts in spotlighting mental health, and more importantly, addressing it. The mental health roadmap, everything that Councilmember Rivera spoke about, and Councilmember Baccio, their personal experiences that they bring to bear. It's inspiring and it's important, especially during this time when we as New Yorkers see the mental health struggles of our neighbors literally outside of our front door. And I think this is a different time. It's post-COVID. It's a realization of mental health awareness. It's a national issue. It's an international one. So I think we have to be grateful for anything that mental health is no longer as desperately stigmatized as it has been in previous points in our life, but there's a lot more work to do. I'll just say this, the state budget that we're working on, and we hope to have it signed soon, has historic investments in mental health, including over $1 billion in additional funding for mental health care for local communities, $18 million capital, $30 million in operating fund to expand inpatient psychiatric beds, 850 new beds. The previous governor slashed hospital beds for mental health. Again, there was a counter movement back in the 70s that stigmatized large mental facilities. Now we, I think, have come to the conclusion that we need more treatment beds, and we're moving toward that direction. In connection with that, we're in our Senate One House, we have $10 million for a pilot of a bill called Daniel's Law to support increasing access to emergency mental health crisis counselors for local law enforcement. I know that's another council issue and initiative here in the city. We're adding money for
Seconds,
workers.
Brad.
Okay, one more second. We're adding money, an 8.5% cost of living increase for all those workers who deal with this on the front lines. And then we're pushing a lot of legislation around youth suicide prevention, making certain that that the state applies for federal money, which is an initiative that I've taken up with my council members, including Councilmember Botcher and Assemblymember Simone. But thank you for being the think tank on this issue, bringing experts together. I'm going to take a lot of notes and appreciate the opportunity. Thanks so much.
Thank you, and thank you so much for advocating on this issue at the state level. Of course, thank you also to Councilmember Rivera and Botcher, who's about to speak now. Eric.
Thank you so much, Susanna, and thank you so much to Community Boards 2, 4, and 5 for putting this together. Very, very excited to see the results of this collaboration and all this great thinking that's going into helping us unlock this very big problem. I feel optimistic for the first time in a long time. I think our collective advocacy is beginning to work, and the governor's announcement in January of proposal for $1 billion towards mental health and a major effort to restore the psychiatric beds that have been shed. The mayor's mental health plan that was released that included a big expansion of clubhouse capacity and big investment in school-based telehealth. The city council, as Councilmember Rivera alluded to, released earlier this week a mental health roadmap that was a result of a year of work put in by our policy team with the leadership of Mental Health Committee Chair Linda Lee. And I'm going to put the link to it in the chat for everyone to see and read because it's quite voluminous. But in it, we identify, we put into 4 buckets. Number 1, the prevention and support services. And in that, we are including legislation that would require the city to establish 2 crisis respite centers in each borough. And a crisis respite center is a place for people to go after they've been hospitalized. What we're seeing is this hospital to shelter loop. And it's really a hospital to jail to shelter loop where people go to the emergency room, they're out the next day and they're right back on the street. We need crisis respite centers, a place where people can actually recuperate and get healthy and get services. Those do not exist.
30 seconds, Eric.
Now. There's also legislation that would require the city to expand clubhouses like Fountain House. Very important because we forget that on a very basic level, people need things to do during the day. They need places to go. You can't expect people just to lay in their beds all day and watch Netflix. They're going to be out and about, and we need places for people to have friendship and opportunities for vocational opportunities and other things. That's why expanding those is a huge priority of mine. The mental health workforce shortage is perhaps one of the main roadblocks we're facing because you could throw all the money at this problem in the world. We have all the great ideas and the right solutions, but we have a major shortage of mental health workers and social workers. So we don't even have enough people to fill the jobs that we're already funding. So the council is going to be initiating a social work fellows program. We're going to be fighting for more salaries and more funding to make these jobs actually have pay parity so people want these jobs and stay in these jobs. The criminal justice system, big intersection here because we've really turned to the criminal justice system as an alternative to mental health care. And now the prisons and jails are the #1 provider of mental health care in the United States. So the council has a slew of recommendations and actions that we're going to be taking to help with justice involved individuals and to really help get us out of the hospitalization, discharge, arrest, incarceration cycle. And then public awareness, interagency communication. I have a bill that would require the Adams administration to conduct public outreach as well as educational and enrollment campaigns on mental health services available through NYC Care. NYC Care is the program through which any New Yorker, insured or uninsured, documented or undocumented, has full access to the healthcare services provided by health and hospitals. But they have not served nearly as many people as they are capable of.
Thanks, Eric.
Thank you so much.
Thank you, everybody.
And thank you for putting that into the chat. A lot of information for people to wise up on. I think we also have Assembly Member Tony Simone here.
Hi, everyone. Thank you, Susanna, Maria, Renee, Committee Boards 2, 4, and 5 for your leadership on this. Thank you to Eric Botcher, the council, and to my colleague, State Senator Brad Harlan Siegel. Mental health is a major priority for the Assembly as we are in budget negotiations. I hope very soon that we'll have a budget finalized. And one of the main things I want to emphasize on the mental health crisis that we see playing out in our streets, a lot of us have personal experience losing friends during COVID and the pandemic to the mental health crisis. It's been a priority for me when I was running for this seat and now as an Assembly member. We all know very well that we can have all the services in the world on the ground and supportive housing, but they won't function well enough to achieve their goals without effective workers staffing them. Many programs, as Eric mentioned, are plagued by high turnover. I've met with many human service workers in Albany. In order to ensure a dedicated workforce, we're fighting for a long overdue COLA for them at 8.5%. I'm not sure if we're going to get it, but we're fighting to the very last minute to ensure the folks that are on the front lines get paid to be able to afford to live in this city and also help with the mental health crisis. We will never solve the public safety problem and the crime issue unless we deal with the mental health issue. Some of the specific numbers, I won't mention them all for sake of brevity. We've pushing for $890 million in capital funding to create 3,500 new residential units for New Yorkers with mental health disorders, $60 million to increase the 998 crisis hotline's ability to support callers. We also want to provide $9.3 million to create assertive community treatment ACT teams, providing high intensity care to New Yorkers of all ages with serious mental illness. Provide $3.3 million to establish the Individuals Placement and Support Program, which will help New Yorkers with serious mental illness secure employment. We all know that substance abuse is often an unfortunate result of those struggling with mental health without adequate quick care. We see this in front of our eyes. When I walk down the street with my dog Radar and my husband, we've seen a lot of folks out in the street shooting up and not having the intake centers. We need to move that inside, outside.
Thank you, Tony.
Yeah, and just want to finish off that we're also looking for funding to fight substance abuse, which I can provide the numbers later since they're not final. But thank you for holding this forum tonight. I look forward to learning a lot.
Thank you, Tony. It's always a pleasure to see you. And also Linda Rosenthal is here.
Hello, everyone. Assembly Member Linda Rosenthal. I represent the 67th Assembly District, the Upper West Side, parts of Hell's Kitchen. I just came back from Albany. I'm still sitting in a car, so that's why you have the lovely decor behind me. Thank you all for holding this informative town hall. We can always learn something when all these boards get together, and thank you for inviting me as well. You've heard a lot about the numbers from my colleagues, and we think that putting a lot of funding toward mental health services, increasing the COLA probably by 4%, even though we wanted 8.5%, for workers who are expert in handling mental health and issues. opening up 150 new psychiatric beds in state facilities, adding a lot more money in various places that need it, raising the amount of Medicaid reimbursement to hospitals and to outpatient clinics means they can serve more people. And that's exactly what we need to help and serve more people. And obviously, this is not an issue that's confined to New York City. This is something that my colleagues around the state are talking about. And so, you know, the crisis is big, but it's not just us. I also have some legislation, licensed school psychologists so that they can operate outside the school building, because we have found, we've gotten calls to the office that parents with kids in schools cannot get an appointment with the school psychologist because there's such a heavy demand. If they get licensed, they can work outside the school and deal with school-based issues that kids have. I also have legislation about
30 seconds,
training.
Linda.
Training
30
for,
seconds left. Thank you.
Okay.
No,
No
you-
one else abided by it, but I will, because I
Okay.
know you have a big agenda and I don't need to bloviate. But I have a bill to have training for everyone who works in a shelter, because they are not all trained in how to handle people with serious mental illness. I'm working on the substance use disorder problem, and we did put a lot of money toward treatment and education to help people get on the road to recovery. So you can proceed. I'm sure it'll be very interesting, and I hope to see you all soon in person. Thank you.
Thank you. And thanks to all of you for attending tonight and for sharing with us all the ways in which you're advocating on this issue. You're welcome to stay in the meeting and listen. You're welcome to turn off your camera. You're welcome to go have a drink and go on with your life. We'll now turn to Maria.
Thank you, Susanna. It was great to hear all of you speak about what is happening. I heard a lot of numbers and dollars, which to me is a really good thing. Before we move on to our panel, I just want to provide some background about our topic tonight, which some of the electeds actually alluded to or mentioned. Over the last 50 years, the approach toward mental health has been to move people out of state hospitals living in poor conditions and move them to communities where they live. Unfortunately, the community services that should have replaced state hospitals has not developed an infrastructure that can support the need. We see this in our own communities. The people who appear to suffer from serious or severe and persistent mental illness and who appear to be poor, maybe homeless, and unconnected to services. In October of 2021, CB4 and CB5 held a mental health forum about the services and gaps that exist. The gaps that were identified were, number one, housing solutions, be it supportive or independent affordable housing. Number two was access and coordination of services. And number three was treatment capacity, which includes reimbursement for services and the impact that it has on what is currently provided. Both professionally and personally, I think it's great that governments at all levels currently are speaking about this issue a lot and have come to recognize the need to do better and provide compassionate care to people who struggle with SMI. Both our governor and our mayor, and now city council as of this week, mentioned having plans to devote significant dollars to providing this care. The common refrain you're going to hear is that we all need more housing, specifically more supportive housing and more hospital beds. We all agree. However, bricks and mortar solutions require a lot of capital. They take a lot of time to get things approved and to get them built. So what we see is an urgent need in our communities that deserve to be addressed right now. So we are asking, what one or two things could the city do that can be implemented on a short timeline, maybe even with allocations in the budget being negotiated right now in City Hall? That's the focus of tonight's discussion. And we've decided to pool our efforts with all the community boards below 59th Street in Manhattan, because all of our communities have experience with this, whether it's at the Port Authority, bus terminal, Penn Station, Washington Square Park, or 100 other public spaces. So we welcome you to this conversation. Renee.
Hi. Right now, I'd like our experts to introduce themselves. I'll start with Ellen Moore.
Hi, I'm Ellen Tabor. I'm a psychiatrist. I'm the Associate Chief Medical Officer at the Institute for Community Living. And I actually work on ACT and IMT teams. I make home visits in the Bronx, as well as my whatever administrative responsibilities. At ICLR, I visit and supervise people working on ACT, IMT, and shelters. And I made a mistake earlier. I said I live in CB5. I actually live in CB6 in Manhattan. So
And
this
we're
is
gonna
my neighborhood. What?
And we're gonna get you to explain to us later what ACT and IMT stand for.
I will be happy to do that. Really, can I just say also, I'm really happy to see my city council person, Carlina Rivera, here. So it's really nice to see her.
Great. Brianna Thompson and Abby Boynton, they're both from the Center for Alternative Sentencing and Employment Strategies. That's called CASES. Brianna, would you like to introduce yourself?
Sure. Hey, I'm Brianna. I'm a psychiatric nurse practitioner and I work on 2 of the IMT teams at CASES, and I previously worked at ICL on ACT and in the shelters and the clinic. Yeah, and I don't remember which community board I'm in because I can't remember the districts, but
it doesn't matter.
Yeah, some of what you do I know is in CB4.
Oh, okay. Yeah.
Abby, would you like to introduce yourself?
Yeah, my name is Abby Boynton. I am the assistant team lead on one of the CASES intensive mobile treatment teams. I previously worked as a social worker on Rikers Island, which is sort of what led me to this career path. And I'm very happy to be here.
Thanks. Finally, we have Dr. Van Yu, and he is at the Center for Urban Community Services and also its healthcare arm. Dr. Yu?
Yes, hi, thanks. I'm Van Yu. I'm a psychiatrist. I'm the chief medical officer at CCS at its healthcare affiliate, Janney Medical Care. I'll just list very quickly some of the stuff we do that's relevant to the conversation. We operate a lot of supportive housing, a couple shelters, couple safe havens, drop-in center. We are the lead organization of the Manhattan Outreach Consortium, which does all the service outreach in Manhattan. We operate 8 intensive mobile teams and an ACT team, all of the ACT teams in the Bronx. And then Janney Medical Care provides the psychiatrists and primary care providers for all of that, including the street outreach psychiatrists and the street medicine providers for the Manhattan Outreach Consortium.
Great, thank you.
We're going to turn to questions of the panel. I just want to jump in before Maria takes her turn. We've heard the term ACT and IMT a lot already tonight, so I think someone needs to just explain what those are, because this is clearly a program that we've become very interested in. I think, Ellen, can you just take a quick stab at, and then everyone will know what we're talking about?
Sure. ACT is very old. The ACT teams have been around for, I don't know, 30, 40 years at least. It stands for Assertive Community Treatment. And in New York, they are operated out of the State Office of Mental Health in Albany. What they are is it's 67 patients who are assigned to a large team with psychiatrists, psychiatric nurse practitioners, RNs, LPNs, and lots of social workers. Most of them are housed. Some ACT teams go to shelters. Most people live someplace, whether it's NYCHA, family home. Some people, as I said, live in shelters, and we visit them. And when I said I make home visits, that is what ACT teams do. We go to people where they are and we meet their needs. We work with them, we get to know them, we find out what they want, we take them out for breakfast, we clean their apartment, we drop off meds, we give shots. We help them find jobs. We help them go to the next step of independent living. People stay on ACT teams for anywhere from 1 to probably 5 years. And during that time, they make very close relationships with the team members. And in so doing, we sort of model healthier behavior as they get ready to move on. They all have severe mental illness. Every single one of them has suffered severe psychological trauma, and we work with that closely. Many have substance abuse problems. Whatever they have, we will work with it. IMT stands for Intensive Mobile Treatment. It was created by Mayor de Blasio around 2017, I think. So that's run out of the State Department of Health and Mental Hygiene, DOMHMH. It's sort of like ACT, but more intensive. The teams are small. The number of patients is small. The number of staff is large. It's 27 patients. And they may or may not be, most of them have forensic involvement. They have been in and out of, say, Rikers. Many of them are street homeless. Many of them resist engagement. It is not outreach per se. We know who we're supposed to go see, but they may not want to be seen. So we look for them. And there are a lot, people, they get I think 2 visits a week at least, and different team members, again, psychiatrists, psych NPs, RNs, social workers, and peers. I didn't mention peers on ACT, but we have peers on ACT and peers on IMT, and in most places in the public system, peers are people with mental illnesses who are in recovery, and they have walked the walk and they talk the talk, and they get a lot of respect for that. So the IMT teams are really doing a lot of looking for people and engagement, and it's less treatment per se, fewer people on medications and so on, but more what we do is work very hard to find people, connect with them, and try to make a relationship that will lead to treatment, safety, whatever they need. But it's a step almost before ACT. But that is only in New York City. I don't know of any other place in New York State, let alone the rest of the country, that has something like IMT.
Can I jump in, Ellen? Thank you so much for explaining that. But just for clarity for folks who may not know, and because I just came to my question, ACT teams and IMT teams, they are not mandated, or are they?
No, they are not. And we can talk about that later on. I think it's such a good question. But many people who are on the teams, they are assigned to the teams. Actually, they are mandated. People don't have to meet with us, but we have to try to meet with them. Many people will have court orders around their medications, but they may or may not choose to see us. But actually, they are assigned. I don't know if mandated is the right word, but they're definitely assigned.
I meant court ordered, excuse me.
There's no court order for ACT or IMT. There's court order for events.
Thank you for clarifying that.
Sure, I'm glad you asked that. Thank you.
But then a lot of our clients do have court order treatment that are on the team once,
Thank you, Brianna. I'm going to jump in, Renee, with start with my question for Dr. Yu. Thank you, Ellen and Brianna, for clarifying some of that. Dr. Yu, so most of the folks here tonight live and work in community boards below 59th Street. And I'm curious, what needs do you see out in our communities? And is there a need for us to call for an increase in services in our district? And if so, well, I'll stop there. I don't want to give you too many questions.
Yeah. I'm gonna say one sentence about long-term stuff that's been mentioned by a lot of people already, which is basically that if there aren't enough places to go, it won't matter, right? So that's supportive housing, drop-in centers, shelters, hospital beds, things like that. So I think people already have said that, and we all know that. So now I'll move on to the question at hand, which is my understanding of the question is what's something quick that might be of high leverage and high value, and the thing that I think would be the highest yield potentially thing is something that's also been mentioned by a few people here, which is the cost of living adjustment. There's a big workforce problem amongst social service workers that work in this space, and also the clinicians, the psychiatrists, and the primary care providers that work in the space. I'm a physician, so I'll sort of focus on that there is a really critical workforce shortage among physicians and other providers to begin with, which is most acute in the primary care specialties, primary care, pediatrics, psychiatry. And that is even more acute in this space. If you spit in Manhattan, you'll hit a psychiatrist, but none of them work in this space, right? So there's a healthcare economics problem that I won't get into here. And the vacancy rate at all these, agencies like mine, agencies like Cal Ellen's, the outreach teams, all these are really high because of, and money's to be frank about it, money's the big issue, right? Among all the other things that encourage or discourage people from working in these settings. And then the last thing I'll say for now is that in addition to all these places where you're gonna direct funding to beef up services, I don't think you necessarily you don't need more outreach teams. There are enough outreach teams. There's just not enough workers on the outreach teams, right? The city's already divided up. in nice catchment areas for the outreach teams that exist. We just need more. We just need to actually staff those outreach teams to the extent that they ought to be staffed, right? And there's vacancy rates on all those teams. But the other thing I want to say was that of all to not neglect the parts of the system that I work in, right? So this is a little self-serving, but one of the reasons why you have psychiatrists and primary care providers like trying to, provide care in Tompkins Square Park is because a lot of people who are unsheltered don't access the care that actually they could access in brick and mortar places like clinics and health centers and hospitals and Bellevue. Like I actually used to work at the Comprehensive Psychiatric Emergency Program at Bellevue. It's a great program. It should be expanded, right? But a lot of people just won't go to these places by choice. So that's why there's a lot of people like me. I go to where the person is. Like I literally meet people where they're at, including Tompkins Square Park. So just not to neglect that group of people. And again, those services already exist. They're good services. They're just understaffed because of workforce problems. So I'll stop for that for now.
Mm-hmm. And what do you think, considering what you're saying right now about being out, not expecting folks who have serious mental illness to always come to a place, but us going out to serve. Thinking about that, and Susanna and Renee, you're welcome to jump in with any questions also, but what I really want to get at is asking you, like, what programs or what services for these folks do you think is best from your experience, professional, personal?
Yeah, I think one of the things that people may or may not appreciate is that if an unsheltered person outside, often that person, it's not that they haven't been offered all kinds of things, including housing. It's that people often decline what they're being offered. Okay, so what do you do about that? So there's a literature dating back to the 80s showing that one of the ways, it's not the only way, or it doesn't always work, but one of the ways to address that is to nurture a trusting relationship with the social worker, with the psychiatrist, with the street medicine provider. And that takes a lot of time, right? So I'll tell you a story of something I used to work in the financial district doing street outreach. And, there was a group of guys I used to visit who would just tell me to go away, basically, right? So I just started bringing them coffee and basically trying to bribe them with coffee, right? And after, weeks and months of stuff like that, some of these guys would start talking to me, and that would be like the road to getting them engaged in services. So my point of saying all that is that you have to keep funding and supporting that kind of operation, that people reaching out to people, and that trust formation, that relationship formation takes time, right? Oh, sorry, my phone's ringing or something. And this is the last point I'll make on this, is that, and that really works. It works well. So I have some numbers. So the Manhattan Outreach Consortium, just in the last 12 months, has placed 350 people in permanent housing and 1,000 people in transitional housing. There's probably 1,500 unsheltered people in Manhattan. So if you do the math, we should have cleared the whole thing by now. But the problem is that every time we place somebody in a place, they get replaced by somebody else. Like that, I don't totally understand. We've been operating outreach in New York City the way we have been since 2007. The Manhattan Outreach Consortium has placed enough people in housing to have eliminated the unsheltered homeless population of Manhattan 3 or 4 times over by now. But these people just keep getting replaced by other people. And that's a phenomenon that also needs to be looked at some point. So anyway, my point of saying that is that what we're doing is effective. So keep supporting that and support it more. We're also, again, I'll say it again, we're understaffed.
I wanted to ask Ellen about 2 things, ACT and IMT. In doing our research, on this, we kept circling around these 2 ideas. because there are already providers out there who are doing this. And it's not a cheap program, but it's $1.5 million, $1.5 million as opposed to whatever billions to build something. And they're very low, high intensity, right? Staff of 9 for 27 people or a staff of 9 for 60 people. And they do what Dr. Yu is talking about, which is they really concentrate on building this relationship. And yet I guess that this problem of, they have a couple of problems. One of the problem is, as Dr. Yu identified, there's just not enough staff for them. And the other question that I have is, you said yourself, Ellen, that people are on these for quite a number of years. Should we be advocating for something like that if it doesn't move people quickly?
So this is getting into sort of a philosophical question that I think is really interesting. ACT teams are not meant to keep people off the street. They are meant to keep people out of hospitals. And they are meant to keep people in treatment, on their meds, or if they're not on meds, at least in a structured world, because what Van said is so true. If you have a trusting relationship with a care provider, you're going to be on less medication probably. You're going to probably use fewer drugs. You are going to be a healthier person. We all know that. And it's not just common sense, but it's borne out by the literature. So ACT is not when we're talking about what do we do with homeless people, what do we do? By the way, I think we get new homeless people from Florida and other places, I think. And also Paul Krugman's article in today's paper talks about rents. The rent is really too darn high. And a lot of people become homeless. And that is a traumatic experience in of itself. So we can go, that's a tangent. I'm sorry for being tangential. But so the thing about ACT is it's not addressing the problem that we're seeing. And if you went up to, like I'm going to the Bronx tomorrow, everyone I'm seeing lives in a place. They may or may not be on their meds. They may or may not be in and out of hospitals, but they're in a place. And the struggles we have are different. IMT, it's not exactly outreach, but this is the population we're struggling with, where we visit them a lot. We bring them coffee. We do that with our ACT patients too. We take them out for breakfast, lunch, and whatever. We bring them shoes and socks. And, if they move in someplace, we get them furniture, and we really give them stuff, which, also comes from the state, which we appreciate so much. But it's a really long process to make these relationships. There was somebody on an IMT team in the Bronx who actually lives at 27th and Broadway. You may have seen him if you walk by there. He's harmless. He doesn't talk to anybody. He was identified as a person in need of services after 2 years of saying 0 words to our team that faithfully saw him twice a week, every single week. He was finally discharged because we couldn't make that connection. But he is a homeless person that people will identify as someone that they feel frightened by. And he's fed by all the restaurants in the Nomad area. I mean, he's really part of the community, but he's someone that people passersby don't necessarily want to see. And I think whenever we see homeless people or unhoused people, many of us will feel threatened by them because they're seen as unpredictable. There's one other thing I want to throw in there, though, when we talk about what we do. And when Maria asked, are people mandated to these teams? And they kind of are, but kind of aren't. I mean, if they won't meet with us, well, we can do something about that. But the other issue that I just want to throw out there is engagement is great. We need more staff. We need to pay them more. The differential between the cost of living in New York and the amount we pay these people is, humongous. So people can't necessarily, who want to do this work, can't necessarily afford to live here to do it, which is a shame. But the other disconnect that I have is that we have a very strong value and belief in individual liberty. And unfortunately, people's individual liberty to refuse treatment can interfere with our ability to help them. And the court system, I've lived in New York, I shouldn't even say this, for 30 years, and I've worked always in the public sector. So I've seen changes in how the courts respond to our request for involuntary treatment and something called AOT, which is Kendra's law, which I think everyone's probably familiar with. And they've become increasingly restrictive in our ability to provide treatment to people who don't want it. And so that's a separate but highly related issue. You can't force people into substance abuse treatment. You can't force people into housing. You can't force people to take medications almost ever. Excuse me. And I think this is anything, I do believe throwing money at problems tends to make them go away, but this is not a money problem. This is actually a political, elected officials, a political problem and a philosophical problem that has undermined even those people who do this work, their ability to do it.
Thank you, Ellen. I'm wondering if we could turn to Brianna and Abby. I'm just following up on your comments, Ellen, about the individuals that people are seeing on the street. Abby, I wonder, people are generally frightened. They see people who they may be perceived as dangerous or violent, and they maybe probably are not. What do you see when you actually do the work daily, and what is really needed in your role as you go out and meet these people?
I mean, what I see daily, and this is sort of the reason that I do this work, is all of our clients are truly wonderful people and have the way their minds work is one of my favorite things about them. And just talking to them and having a conversation with them is a different experience than you would have normally. I think that Dr. Yu is correct that like one of the biggest barriers is getting people to accept the treatment that we're offering. And the biggest resource that we have is being able to offer them incentives. So whether that be food or coffee or clothing, shoes, those types of things. I think like having the ability to provide these people with things that they need, just basic necessities that a lot of us might take for granted, is invaluable. And so I think like even just increasing the budget to be able to provide those types of things would be incredibly helpful. So that's one thing that I think would be helpful in my work.
Thank you. Brianna, do you have anything to add to that?
Yeah, sure. So yeah, you mentioned that they are perceived as dangerous or violent when people interact with them. I mean, there are clients, they do present the same way to us, but we do know we are usually given referral information. So we do have some insight into like their background or maybe like their family members. So we can use those things to better engage them and maybe de-escalate the situation. If you bring up like a family member that they really get along with, and it can kind of calm them down sometimes, or, we have de-escalation training. So if the client's not able to de-escalate, then we will, we can activate EMS if it's not working out, or offer medication changes. So we're there, like we're able to monitor the clients better if we know them and or they're connected to us.
And do they seem to you like they're hurting? I mean, it's a sort of dumb question, but.
No dumb questions exist.
Yeah, no, we have one of our clients, he specifically tells us all the time, like how grateful he is for like us just being kind to him, because yeah, Abby, you know what I'm talking about. He says he's like embarrassed to go into places because of how he looks and like his poor hygiene. So he's,
Yeah, and this client in particular, I mean, like we had a really hard time getting him to build rapport with us. Like it really took a very long time for him to even agree to work with us. And he was aggressive towards us, towards staff, but eventually we sort of learned that was his coping mechanism, and that he would sort of test us to try and see if we would stick with him, which we did. And what we saw from that is like him really building this trust with us. He has said to us, like, I'll do whatever you guys ask me to do, just don't leave me alone in this. And yeah.
Excuse me, Abby, when you say a really long time, what does that mean to you? And
in this particular situation,
yes.
it took us about 8 months probably to
get
him.
I would say it was slow steps. Like at first he wouldn't step inside our building, but then he would come inside, and then we were able to take him to like the hospital, get checked out, and
yeah,
little by little. Brianna and Abby, I want to start with you. This is the lightning round, short answers. Okay. What would you, and I'll start with you, Brianna, since I see you in my screen. What would you like to see implemented on a short timeline? And just to be clear, short timeline, what we mean specifically is something that can be implemented within approximately a year. What would you like to see implemented?
Yeah, so I think one thing, well, with our IMT clients specifically, we, with the new drugs that are being put into circulation, we are having trouble getting them access to like services. So I think that could be something that could be, I mean, I'm sure the outreach teams already are trying to connect them with services, and we are too, but I'm sure you've seen in the news, like the xylazine now is in the mix. And so more education about that could be really helpful. We have a client, I believe he has a skin reaction from xylazine. So pretty scary.
And Brianna, you said access to services, specifically what?
I guess maybe more like information to where they might be, whether they might get the services, or having like Narcan more readily available. I mean, I know that they just passed where you can get it from this pharmacy with insurance. So that's great. Abby, can you think of anything else for the?
I mean, in regards to treatment, I would say like this client that we were referring as well, who we're concerned is using xylazine. We have tried to get him into treatment, and there have been periods where he is willing to accept entering recovery. We have not been able to get him accepted by any treatment programs. So there's a lot of things that come to play, like risk factors that, might increase or decrease someone's likelihood of getting accepted at that very brief window that they're willing to accept treatment. So I think for a lot of people who use substances, there is that very small window where they want that treatment. And if we can get them in that treatment in that brief moment, that would make all the difference. But unfortunately,
I'm sorry, Abby, let me just cut you off. I'm gonna ask you and Brianna a little bit different. Thinking about, and I know there's a high correlation, like, right, with people who have SMI and substance abuse issues. What I want to ask you specifically, also right now, but I did write down what you were saying for some short timeline solutions, is about folks that struggle with SMI minus the substance abuse issues.
Okay.
Got it.
More SROs or single room occupancy options. Most people who do not want to enter shelter don't want to because it's not safe for them. They don't feel safe. They don't feel supported. They feel that it's dirty. If they have their own space, even a tiny room where they can shut the door,
that makes a world of a difference. Yes. It does. And what would, Abby, what would something be you would say that doesn't take, let's say, not a lot of capital, not a lot of time, not a lot of a process, perhaps something that already exists, but expanding it?
I mean, it's such a weighted question and difficult to answer, but like, even just changing societal's perception of these people, like, I know that they can be frightening to people, but
changing perception.
They generally are not dangerous. They have like our director normally says they have more bark than bite. And a lot of it is coping mechanisms, a lot of it is testing us. And so just knowing that like a lot of these people are not dangerous. Like when I worked at Rikers, I had people who would literally steal to get a place to stay. And they would tell me that like, I had no place to stay. It was cold. It was the winter. And I took someone's phone because I knew that I would have a place to stay for the whole winter if I did that.
Thank you, Abby. That's I like that one. And Brianna, same question. If it's short-term solutions, something that could be implemented in a year, something that already exists, what would you say?
I mean, you've already mentioned the brick and mortar ones, but it seems like those are off the table for now, like the more drop-in centers or safe haven beds, or those like.
No, I hear you. We know that those are really important and matter. Drop-in centers, safe haven beds. What would you say? Short timeline. That doesn't need to be built. That doesn't take a lot of capital.
Yeah, I don't have a good short-term solution.
We can come back to you. If you think of something, just interject. Okay. What about Ellen?
Good. Thank you. Dr. Yu. I am one of the things that makes these people scary is their hygiene. And I wonder if we could take existing, by the way, Abigail, I completely agree. People are afraid of the shelters. We could reconfigure the shelters. This is just walls. Give people a private space that's theirs with, I don't know about a lot, but something where they can close the door and be safe and have their stuff. And their stuff is really important. It's all that they have. It may not be very much, but it's theirs and they value it and they want it. So a way to, that's, I think, a short-term thing. And the other thing is to have, I know, like, I think Trinity Church does this, but to have like showers and clothing rooms where people could go and get a haircut and take a shower. I had somebody last week who just said, I really need a shave. I don't think he's shaved in a year, and we're going to get that for him. But that make them feel better about themselves and they will feel less scary. And I don't think that's I don't think that that's an expensive or difficult thing to implement.
Thank
Yeah.
you.
There's also a public shower, I think, in Harlem, but you have to like sign up on a list. And so it's difficult for our clients to do that in a timely manner.
We want to lower barriers. So like, just make sure there are, thank you. You know, drop in is key, and clean clothing where they can just swap out, and shoes and socks, especially socks. I've seen the homeless work outreach people up in front of Home Depot on 23rd Street with the vans and the socks and the warm food. And it's really important.
Thank you, Tabor. Dr. Yu?
Yeah, there was I think Abigail and Brianna mentioned the substance use, especially the opiates, those fentanyl and the xylazine. I think something that could be looked at is to support more like outside substance use treatment with with a harm reduction focus, like getting more Narcan kits out there, getting more Suboxone treatment out into the community, and that would require, it might require some of the workforce to be trained to give Suboxone, to induce Suboxone. So Suboxone is a treatment that could be used to replace opioid use. It's a little like methadone, but I won't go into all the differences. And that I think there's been like a reticence, I think, among some treatment providers to be more free about giving Suboxone to people, especially people who are unsheltered and who are sort of like unstably engaged in care. I think people are more afraid than they ought to be about it. So not only material support for providing that kind of substance use care outside, but also like some training support, I think. Training support, and also maybe like, not exactly political support, that's not exactly what it is, but it's something like the city, like the Department of Homeless Services, for example, like encouraging people to do Suboxone inductions like outside in places where traditionally providers might be a little nervous to do it.
Okay. Thank you. Renee or Suzanne?
Well, I haven't heard any of you mention increasing the budgets for IMT teams, which I expected to hear you all say. Is that just given for you?
I mentioned it.
I mean,
yeah, and
you all
agree
think
with
that would be something that could be done? I mean, if
I want to say something about that. I said earlier that there's already enough outreach teams. However, because the outreach teams are divided into these geographic areas, right?
And you mean the homeless outreach teams?
Homeless outreach teams, right? But in terms of mobile teams, that's people. That's 27 people, right? There's way more than 27 more people who could benefit from IMT engagement. So like basically, it's like, well, how many people is it? It's 270 or 2,700. It's divided by 27, and that's how many more teams would be beneficial.
And we have waiting lists on those teams now, don't we?
I'm sure we do. Yes, I'm sure we do, and I'm sure the lists are long.
600 or yeah.
So lots of people.
I believe it.
I'm sorry, did you say 600 people on the waiting list?
That's what I've heard. I don't know if that's accurate, but that's what I've been told.
Okay.
We'll get
At least 1,000 per act.
It's high.
Oh, yeah.
One of the things that we are trying to do is increase capacity on ACT teams by creating something called flexible ACT, where people may need fewer visits, but they can't get their shot someplace. So we would maybe have like 600 patients instead of 68 patients, because 500 of them would be just getting a monthly shot. I made that number up. In Europe, it's in Holland, it's 200 or 250. But to be more flexible in our conceptualization, one thing that I do want to mention though is when we talk about, like I mentioned, people can be on a team for 5 years. I think the risk is that when we say, well, now they're ready for a lower level of care, that may not actually work. And so we need to be very cautious about that. We wouldn't tell a diabetic, well, you're stable on your insulin, so now we're going to take away your insulin. And our patients are just as fragile and just as dependent, not in a bad way, but in a real way that they need this treatment. And so if we make more teams, which sounds like a great thing to do, we still have to staff them. And that comes back to what Van was saying.
I was going to say that, you can open up
Money.
10 IMT teams, but if you can't staff them, it doesn't matter, right? I want to say something about the ACT thing, about people being cycled off of ACT teams, because I agree with Ellen that I think ACT teams should be conceptualized as like part of the community mental health system, like brick and mortar clinics. If like I go to a clinic in the community mental health system, I'm not going to be asked in 5 years to like switch clinics. Well, think of ACT teams as clinics. Why would we ask people to switch clinics? It works, and it works really, it's probably also really cost effective. Someone should make that point, right? So I think ACT, once you're on an ACT team and it's working well, I don't think you should touch it.
And so even when we're talking about the whole, putting aside the whole question of whether people should be compelled to be evaluated or not, people who want these services are already not getting them because he's waiting.
That's right.
And we should remember that one of the plans that the mayor has for people in Rikers, and it's been talked about a lot, is to switch incarceration for treatment. So we still need to figure out how to make that happen. And that would be a mandated situation. That wouldn't be voluntary. Or, I mean, people might say, yes, I'll do it to get not to go to Rikers, but then if they don't do it, they'll find themselves back there. But it's something, again, if we could staff teams to do it, I think it's a fantastic solution. And that would include probably substance abuse treatment, which we're not really talking very much about, but it's really a critical component here.
Yes. Yeah.
So we're going to go to our committees. Renee, you want to start?
Yeah, that's exactly what I was going to do.
Thank you.
Community Board 5, questions for our panel. Raise your hand and I will call on you.
And then, by the way, Community Board 2, after Community Board 5 has its turn, we'll come to our committee too.
And then we will go to the public.
Use your raise hand function. And am I seeing any questions from, I see Mary. Mary.
Yeah, if Brianna or someone could maybe discuss the mobile shower program. It seems like that's something that could be expanded, since the focus for some reason tonight is on something smaller that could be expanded immediately in the next year.
Oh, well, I mean, currently I was just speaking of what I know already exists. And so if we could, expand that, a mobile shower, that would be a good one. I think this one's just in a facility, but mobile would be ideal if, but I think the barrier with this one was that you need to sign up and show up at a specific time, which is very hard for our clients to make appointments in general already.
There was a program profiled in the New York Times, I think it was last year, by Brooklyn Community Services, which is literally a bus that's been retrofitted with showers. So it meets people exactly where they're at.
Oh, amazing. Okay.
There are like a handful of mobile shower models across the country. I just can't remember any off the top of my head, but I want to add that one of the benefits of doing something like that is it's an engagement tool. It's not just the shower, right? Like if the person starts coming for showers and they get to like connected to the shower people, then the shower people say, hey, I got this other person I want you to talk to also. So that it's an engagement tool in addition to the shower.
Thank you. I'm not seeing my CB5 people. I think I'm seeing some CB2 people. Any questions from CB5?
Michael Hirachi had his hand raised. I'm not sure if he's one of yours. He can unmute.
I'm on CB4. I don't know if you want to leave.
I'm going to start with our committee on CB2. I see some hands raised. Ritu, you have a question or a comment?
I have a couple of questions. So one of the things that we have been talking about is workforce shortage. So I have a question and a recommendation. So the first, the recommendation is, sorry, let me start again. What's the difference between an ACT team and a case management team? Because case managers, community case managers meet people, where they are. Can some of the intensive treatment or homeless mental health treatment incorporate case managers. And the reason why I'm asking that is that New York State has probably one of the most convoluted licensing and credentialing systems in the United States. So if the electeds are still on, please fix that. That would be a great place to start, along with Medicaid reimbursements. So my question to the panelist is, how can we use uncredentialed case managers who may be qualified mental health specialists or have previous experience to increase or to supplement the workforce shortage?
So two things. ACT teams provide psychiatric care. We provide, medical evaluations. We give medication. That is something that a licensed professional must do. Whether it's, the MDs, NPs, RNs, and LPNs can give shots, but only MDs and NPs can do psychiatric evaluations, make diagnoses, and write prescriptions. So that's right there. But included in our work is case management. We have a vocational specialist, we have a housing specialist, we have a substance abuse specialist, we have family specialists, and in addition at ICL, which is why I work, we also connect with care coordination to do things like Medicaid applications and referrals. And in addition, we are making alliances with primary care clinics and providing medical referrals as well. So I think, and I've mentioned this thing called Flexible Act, which is being looked at Columbia in a research project and not yet here in New York. It would exactly address your comment that we would have fewer people getting lots of medical care and many people getting lots more concrete services and referrals and assessments for those referrals. And it's a great idea. And as to Medicaid, single payer is the only way to go. Oh, I should also add one other thing, that ACT is one-stop shopping. So we give it anything that's psychiatric, we do the whole thing. And they can't have any other services. So they don't get it. They don't get an outside psychiatrist or an outside therapist, or they can get it if it's not psychiatric, so primary care. So we're supposed to provide that intensive work for people. And I guess the issue is what Susanna said, like, why would you ever get off ACT? And maybe if we're giving that level of intensity, we need to reevaluate that. And again, I think that Flexible Act is probably a way to address all of those things. So you have very large teams, large numbers of people, of patients getting a variety of intensities of services.
Thank you. Wayne Quadler.
Hi, everybody. I don't have a question. I just have a comment. I want to thank all the panelists for doing the work. You're really amazing and doing God's work, and I can't thank you enough.
Thank you, Wayne. That's a nice thing to say. Rachel Yarmolinsky.
Can I just say that that's a really nice thing to hear, but also we all love our jobs. We wouldn't do it if we didn't, and it feels kind of like a calling. So thank you, but also I can't imagine doing anything else. I don't think I'm qualified to do anything else.
I'd love to follow up on that comment, because I am interested again with the staffing and getting enough people to do the work. And I feel like there's a flip side to not having enough people and not paying them enough, which is you also have too much work. You may love your jobs, but I don't want you to get burned out because you have 100 clients. I gather
I have 250.
Okay.
So,
I just feel like how you were supposed to give intensive treatment to 250 people, I don't know.
Because we have great teams.
Okay, I'm just saying it might help. I have a question whether it would help to make sure that people don't get so overloaded that they can't do the job. And this is tied in with not only paying adequate amount of money, that more people want to come into it, and make sure there's a pipeline of people getting trained to do it. But people have to want to do it. And if it's a much too hard job and only saints can do it, you got to make it easier. I do anecdotally, I just remember people when I think New York State merged the mental health care managers with the regular health care managers. And from the people I talked to, it was sort of a disaster on the ground because they just couldn't handle the workload. And if you were mental health, you weren't familiar with the other part. And it was I don't know if it's still going on, but it seemed like a mess. So I just wanted to bring up, perhaps we could define roles, not only how much money you get, but also what kind of a job it is and what kind of a load you can be expected to carry to help solve the problem. Thank you. And thank you again, all of you.
If I could, I'll make a couple of comments about that supporting or preventing burnout is not just, pay people enough. I mean, that's probably the most important thing is pay people enough, but also make the work environments that we're at, you know, as supportive as possible, right? And part of it is what you mentioned is caseloads, right? The bigger my caseload, the more stressed out I'm going to be. So, you know, if instead of having one psychiatrist and, you know, 250 people, it's 2 psychiatrists and 250 people, like that sort of thing. And also adequate like supervision and support and professional development and all these kinds of things. And the second thing I'll say is that one of the reasons why I have trouble competing with other parts of the system for psychiatrists, for example, is people, you know, graduating from medical school and going through training with these six-figure education debts. So if there was some, and the way to get your debts, you know, addressed is like really Byzantine. So if there's a way to sort of simplify and make available more funding for debt relief for social workers, psychiatrists, primary care providers, to reward them for coming into this sector, that could really help also pretty quickly.
Actually, you know, we have New York State OMH is giving grants, like $300,000 for psychiatrists if they $100,000 a year. And for NPs, it's less, but we have like 6 or 7 people at ICL who just got them. It just can't. It was just announced today. So I think you're on point that it's hard to choose psychiatry, one of the lowest paying specialties, if you come out of medical school with $300,000 or I don't know more in debt.
Wait, one clarification about caseload, but an ACT team and an IMT team have by definition very low caseloads, right? That's one of the advantages there, right? I just wanted to clarify that.
Yeah.
Will Benish?
Hi. So in terms of, you know, just a regular community member, if we're out on the street and we see someone who's experiencing mental illness and we feel that they need some help, I mean, is there anything specific we should do? It sounds like there's a good chance that this person is already known by people doing outreach. So is it still helpful to call and let someone know maybe it's one of these different organizations? Or I'm just trying to think, like, you know, in practice, you know, what someone who is not experienced in this field can sort of do on a day-to-day basis. Thank you.
It's complicated, right? I mean, it's a complicated, I mean, obviously we call 311, but what goes on behind 311 is very complicated. I think that one of the things that we're talking about with DOHMH is that there's an effort to make this all more consumer friendly, because I'm going to guess, Ellen and Dr. Yu, that this is not so consumer friendly right now.
The police are not so friendly, and it's hard to make sure you won't get them. I've called wellness checks for people in residences, and you know, when the cops got there before EMS, we don't have any control over that, and they had their hand on their taser, and I said, like, whoa, officer, you are not going to need this. But we need people who don't put their hand on. This wasn't on his gun, but that can't be the first response. I'm not sure what you would do if you saw someone you thought was in distress. I mean, somebody put up in the chat, call 311 and say you have a homeless person in need of services. I don't know what 311 does with that. Maybe somebody else does.
Our understanding is that the District of Manhattan Outreach Consortium, which is required to meet with them within an hour, respond within an hour or two.
Yeah, that's right. So you're right, William, that if you encounter somebody like that and you're concerned about, chances are, yes, one of the outreach teams already does know that person. However, a 311 call can be helpful because it alerts us to something going on at the moment, right? Whatever that might be. And Suzanne is right that those kinds of 311 calls get routed directly to the Manhattan Outreach Consortium, and we send people out to go see the person. And again, mostly we go see the person, like, oh, we know you. And then the other thing that I think should be expanded in the city is BHER teams. Let me see if I get it right. Behavioral health, emergency, I would skip the A is response division, right? So some 911 calls in some precincts, instead of going to the precinct, goes to the BHER team, which is a social worker and an EMS person, no police officer, right? And they respond to those calls. And there is I think there is a plan to expand this into more parts of the city, eventually to the whole city. And for those kinds of mental health calls that get diverted to the Be Heard teams, those have been really, really successful. They've avoided a lot of police involvement, a lot of trips to the precincts. They've avoided trips to the ER even, and it has resulted in a lot of engagement with services. So that would be another perhaps really quick thing to do is fund more Be Heard.
There you go.
What does the BHER stand for again?
Yeah, it's Behavioral Health Emergency. Does anyone know what the A is?
I don't remember what it stands for, but
Right.
it's essentially a different kind of emergency response. It's not
Right.
It's not a continuing care. It's not long-term engagement, but it is a different response to crisis than the
Right. So what happens? when
Who
you call
determines if
911
BHER gets referred?
Yeah, sure. If you call 911 in a precinct that has a Be Heard operation, right, which is not every precinct in the city, it's because it was piloted in like a handful of precincts, then the 911 dispatcher can choose to funnel that call away from the precinct over to the Be Heard team. So the operator's got to hear the story and decide it's appropriate for a Be Heard team. And then the Be Heard team gets deployed instead of the police officers. And again, it's an EMS person and a social worker, right? And their role is to go and see what's going on, and mostly to sort of like engage and then try to connect that person to the appropriate service, hopefully right then, right? Which may include the hospital, but it just avoids police involvement in some of these situations, and it's been really, really good as far as I can tell.
Wait, Dr. Van, have you had personal experience with them coming when you've called 911? Because when I've activated EMS, I haven't had anyone from those units come, so I don't know how.
Well,
many there
partly
are.
it depends on where you are, right? Because again, so the precincts that were piloting it were like Harlem and parts of the Bronx. I think a couple of precincts in Brooklyn now have Be Heard teams. There is a plan to expand it. I don't know the details of the plan.
And it's not 24/7 either, I think.
It's not 24/7, so that's another way to expand it, is make it 24/7. And then there actually, at some point, there weren't enough, there has to be the response to the operator, the 911 dispatcher. So when the 911 dispatcher decides to funnel it to Be Heard, they call the Be Heard, right? If they don't get a response from the Be Heard people within, I think it's like 14 seconds, then they go straight back to the precinct, right? So I forget the reason why sometimes they weren't getting the response within 14 seconds. I think it was just not enough people taking the calls. So like there's low hanging fruit right there.
Yeah,
like,
no, I'm hearing
right,
low hanging through what you're saying.
Yeah.
Some smoothed out system.
Is there a way to check if we have this in our district? Should we
Yeah,
call the
I can
precinct?
find out for you, William, because we have a little bit of information about that. Yeah, and we'll find that. I'll find that out and we'll share that. Actually, we'll probably put that in our report. I see Keen's hand up.
Yes, the Be Heard sounds great. We can say we need it right now, and we need it well staffed, and we need them well paid. And the big political question is, people are wanting more money for the police. Can that come out of the police budget so that we get no?
I'm not saying yes or no. I just think that that's not, that's a whole other discussion.
Not really, because sort of some of the political people are trying to pay the police more. But if we could say, yeah, pay the police more, but their money goes to social services.
I think also there are training programs that have been implemented with NYPD. I think there's actually a lot of work going on with NYPD as well.
Yeah.
I'm going to go on to Ivy, unless are you done?
Yeah, I mean, I'd like to know if that is in fact, how do we get a lot of money to this? That's really the question.
Thank you.
In what William was talking about, how does a citizen contribute, like a path? Like if there was more funding in places like churches, where there was a place for all this know-how people to be there, where people can take a shower, instead of 911, whenever I call 911 or 311, it just it seems that it just goes to the ether. like sometimes it works and that sometimes is very short. So I can't even imagine what it would be like when somebody really needs help. So it would be great if we could fund like places like churches or even like I don't know, it's like not the right word, like tent or something near a hospital where the expertise are there ready versus like everybody scrambled, that eventually community doesn't have to rely on a 311 like ether situation, that where we can activate ourselves to take people there, that we know like how what you have said, Van, where suddenly the person is there and there is the connection of, it's not just a shower, is the connection of, harm reduction. And I will go back to housing work that knows how to do this really well. And I have had conversations with them about why can't you consult in the broader sense where you have satellites and make it, not in the housing work umbrella, but now is more on the ground, because they had 40 years of doing this and they do it really well. But when I talk to them, they always say, oh, we do this and the city won't let us do that. Why can't we bridge that, since they're one of the most successful cases?
Thank you.
A lot of our, to respond to you if I can, Ivy, a lot of our patients in the Bronx, which is where I do most of my clinical work, are living mixed use housing. So and they're run by lots of different agencies. Housing Works is, actually it's not one of them, but I can't remember them all. There are so many. Community Access is one. And so they have X number of apartments that are affordable, X number for people in treatment, X number for community people, people just need a place to live. And those I think work pretty well. And I wonder if there could be legislation. I know that there's some legislation about any new residential has to have a certain amount of affordable units. If we can include another chunk of units for people in treatment, it would be the same, paid by voucher or something to make sure the landlord is whole. But that's, they tend to be studio apartments, and it might be a way to address people want to be by themselves and need their private space and a room to call their own, with their own bathroom and a kitchen and all that other stuff. And it's probably, and they're scattered. They could be both concentrated in a new building and also scattered around the city. It might be a quicker way to help people feel part of the community. Because one of the things we're not really talking about is one way to help everybody be safer is to have these people feel that they are part of our community. And we really haven't done that.
Absolutely, because when one calls on behalf of somebody in distress, there's, I think, a large percentage where you feel like you don't know if you're helping because that 911 may not come. You're dropping people in the wrong place. So it's what Will was saying. If we build like things that are more secure, where citizens feel that they can participate and help with that huge chunk of labor in some ways, yet participating in a way that we feel that we're safe for the person that's in distress.
I want to jump in and
Sure.
interrupt. I apologize, Ivy, but considering the time, it is now 8:02, and we have our panel. We told them that we to be available until 8:30 p.m. We still have some other folks raising their hands. We might have members from community boards 1, 3, and 6 who need to speak, and we would like the public to have questions or make comments while our panel is here. So I would like if we could.
Great. Shall I move on to Michael Barachi?
Yes, please. Thank you. And if we could just make our questions or comments as brief as possible, that would be great. Thank you.
Can you hear me?
Yes.
Okay, great. I just want to say that I am a product of an SRO, of supportive housing, of transitional housing. So Abigail, Brianna, Dr. Yu, Dr. Tabor, I think I'm missing some people. Thank you for all that you do, really. I think one common thread that I noticed in all of your testimonies was not one of you mentioned criminalization. Not one of you mentioned making homelessness, making poverty, making mental illness a crime, right? I think that I agree with Abigail's statement in combating the perception. I think that maybe buying public health ads to combat the right wing, especially media, and oftentimes the left wing too, conflating mental health conditions with people who are dangerous. Don't forget that Rikers Island is basically a torture chamber, and criminalization and locking people up, no matter how serious the condition, is never the answer. We always have to think upstream. So thinking upstream, thank you, Keen, for mentioning taking some money away from the $11+ billion budget that the NYPD blows past every year. We can invest that money back into our communities, including getting rid of the anti-homeless furniture, installing public restroom facilities that are free and or paid, installing in better built environments that enhance public health, and implementing more community pantries across all the boroughs. I appreciate everybody's time. I want to just also say that I do support single payer healthcare. I think that would be a great addition, and increased incentives would be great for the workers pay, outreach, hard and soft services, long and short term goals. Again, I think a big, cheap, quick way to start is really combating the public perception of conflating danger with mental health conditions.
Thank you, Michael. Michael, just to identify, you're a member of the board of CB4?
I live in CB4.
Oh, you're just a member of the public. Oh, okay.
Oh, I'm sorry. Oh,
okay, you elevated him. All right.
Yeah.
Let's go to, I'm not able.
Thank you, Michael.
For some reason, I'm not able to elevate people to panel. I just want to look among our attendees, who is here from CB's 1, 3, and 6. I'm looking for, I saw Elvie here. Maybe Elvie, can you elevate Elvie Barroso under the attendees? I'll give you other names to Francis Curtis.
Tammy's on here as well. Tammy Metzler, she's from CB1.
Yeah. Rita, if you're able to elevate them, I'm just going to go through the names with you. Tammy Meltzer, Pat Moore, she's here, and May Lee, and Susan Stetzer. I don't know why I can't elevate them. All I'm offered to do is to chat with them. So if you have succeeded in, Rita, are you able to elevate them?
Yep, they're all there.
Okay, great.
I'm here too, so you're covered.
Okay, great. So let's start with wait, where am I? Let's start with, we'll just go down the list. Francis? Is Francis Curtis here? Ooh. Well, I guess let's start with Mei Lee from CB3.
She declined to be promoted to panelist, so let's
Oh,
go
no,
to
there's two, I'm sorry, there's two of me. I'm sorry. Hi, this is May.
Oh, there you are.
And I'm signed on to 2 devices. So the other device is just for looking, and this is the one where I can be seen and heard.
Okay.
Okay, so, all right. So, hi, thank you. My question, I heard a lot of interesting discussion today about all the different areas of mental health, and, you can see it's not just one thing. And, people are talking about trying to support one thing, but the Be Heard, the Be Heard programs are, they're not in Lower Manhattan. If you look at their website, they're all, and as Dr. Yu mentioned, they're either in Brooklyn or Uptown. So, I mean, we're all in Lower Manhattan, so it'd be good to advocate for some of that in Lower Manhattan, and I would be interested in knowing how that can be done. But the other thing was, people talked a lot about, was outreach and services, and I wanted to know if the panelists had any thoughts about language access, but how is it done? Do you actually have staff who speak other languages, or is it the telephonic translation? Or, I mean, certainly when you're talking to a homeless person on the street, it's not the greatest way. I heard they just do telephonic translation, but it's really not the most ideal way.
Let's ask Brianna, who's on a team. Brianna, what do you guys do with people who don't speak their language?
Oh, actually, that's so weird because we don't have, we have all English speaking, which is odd, but we do have a translator number that we can call and use it on our phones. But I haven't had to use it yet, actually, which is surprising now that I think of it.
May, anything else?
Sorry, Susanna, hold on.
Oh, we've lost May.
Here I am. Oh, am I?
Okay, May, was there anything else you wanted to say, May?
Um,
But you're right. Okay. Did you get the answer? Sorry.
I was just gonna remind everyone, I'm not sure if I didn't hear a question, but I just wanted to remind everyone again about the time and keeping your questions or comments short, so that we can have time for public.
Let's go on to LV. LV, you're muted.
Hello, good evening, everyone. I'm LV Barosa, and I'm the chair of Health and Human Services Community Board 6. So I don't have any question at this time, but I heard a lot of things, and I'm willing to collaborate on prospective programs that we can develop to improve the services for those people with mental illness.
Thank you so much. I guess I should ask all these people that we've elevated if any of them has questions. If you do, raise your hand and we'll call on you, and if not, we'll go to the public. You might just be listening in. Let's see who I see. I see Tammy Meltzer.
Hey, thanks so much. This has been lovely. Thanks. CB1 is delighted to support. We definitely would love to hear more about potential rollouts of things like the portable bathrooms and showers for the homeless people on the street. It definitely sounds from the stories about the 1,000 touches that you need to get to somebody, the more opportunities you have to treat them with the most humane basic services, the better that they feel about going to get more services. So there's always opportunities and hotspots in every community board. And I think what I don't get is why, with known hotspots, we actually can't get services like haircuts and portable showers and things like that on a routine scheduled basis around to really help people. It seems few and far between, which I get, but so then how do we get them large and out?
Thank you. Thank you so much. Susan Stetzer?
Yeah, thank you. So we have a lot of programs that we want to support, and I think it would be helpful to have more information. I know there's some allocations, like for IMT that's just been allocated more money. I believe Be Heard, and I believe we are now getting a clubhouse downtown. So it'd be really helpful to know, and I guess we need this from our city elected officials, which programs are most in need, which ones we will very shortly be seeing more funding, and which we are not. And then also, it seems we're talking about both city and state programs. So I think like the ACT is state, so that's not something we're going to be including in our advocating for city council. And I'm just trying to be very clear about how we can be most effective.
Yeah, thank you. That's a very good point. We recognize that the state budget is pretty much sewn up, even though they're still up there. But we're going to advocate for what we feel we can advocate for, whether it's this budget or next budget. But I think the short and the long of it is to advocate for, in addition to all the comprehensive solutions that we all know are needed, to also that require a lot of political will over many, many years. We just want to also focus in on these, as Dr. Hughes called it, low-hanging fruit. I see Patricia Moore.
Hi, Pat Moore from CB1, Chair of the Quality of Life Committee. First of all, thank you all the community boards for doing this, and thank you panel for being here tonight. Who should we write resos to advocate for Be Heard teams downtown? And
yeah, sorry.
So, and how do we advocate to have them be 24/7 since they aren't now?
Well, I think that your comments mean that they may very well end up in our resolution, and that's how we intend to advocate it. And we hope that we're going to be able to write a resolution that all 6 community boards can support. We feel there's just strength in numbers.
Great, thank you.
I think we'll go now to the public. Maria, do you want to take that? And we're going to, given the time, 8:14, we're going to ask people to do 2 minutes or less. 1 minute 30 is even better. Renee, you want to take, Maria, you want to take that away?
Maria, you're muted.
You're muted.
I took up more time. Let's see. If you are in the attendee section and you do want to speak, you need to raise your hand. Use the raise hand function on your screen. I am requesting that everyone give themselves 90 seconds or less, so 1.5 minutes to speak or ask a question or make a comment. If someone already said what you said or asked what you wanted to ask, if you could just say, you know, I'm echoing what the last person or the person's name, what they had to say. Anything else that I'm missing that's super important
No, just
to say right now?
before you go to the attendees, Carter Booth of CB2 has his hand up.
Right. Thanks, Susanna, and thank you everybody for attending. You know, one of the shortages that we heard tonight is with respect to trained staffers. What's a quick way to get more people educated? What, you know, that can fill in some of the lower levels of healthcare dealing in this area as far as vocational schools or anything else similar that could help with staffing issues?
Thank you. Does one of you want to take that question?
Well, somebody mentioned there's an awful lot of regulation around here, and we know that's true, but if we could get, you know, a bachelor level social workers, for example, I don't know if they're allowed to work. If we could go into high schools and tell students that if they study this, they can have summer jobs and they can, you know, sort of segue into social service jobs like this. I don't know that high school students know that social work even exists in a way that's not ACS or something. And I think that, you know, if we could recruit more people into training and then find a way to credential people who don't have master's degrees in social work, for example, getting LPNs, if that's a safe thing, you know, instead of RNs. And so people who have training and skills, but maybe less intensive training.
Yeah, we've heard
also agencies should fund people's education so that we can take bachelor's level people and then send them to school. And then they would come back and work for us with their great higher credentials, and we would keep that as a cycle.
Thank you. Thanks, Carter. Okay, Maria, go ahead.
I moved over Katie Stokes and Christine Gorman. Can y'all hear me? I hope this is
Christine Gorman
working.
is here. Can you hear
And
me?
also, Maria, as you call on people, they don't all have to be made panelists. You can just allow them to speak.
Oh, yeah? Oh, I'm so used to doing it that way. Thank you. But I like to see their faces. All right,
whatever you want.
enough jokes, enough jokes. Get it together, Maria. Okay, we are up to Katie.
Hi, everyone.
Stokes.
I'm on HHS for Community Board 4. I want to just thank all of you. I think it's so great, the points you've made about how many touches it takes to be able to establish trust, and so many great ideas. I guess this is following up a little bit on the question that was just asked about, you know, one of the biggest things you mentioned was the workforce shortage. I think the idea of recognizing that not everybody needs a master's in order to do this work is great. But I was also just wondering about where do you think where is there an opening to do something about the low pay? Like, I just was wondering if there is an angle there about what you would suggest about doing something about the low pay. Like, is it setting higher standards or what would it be?
Increasing the budget.
And maybe it says, okay. Yep,
all right, they all smiled. I think that's the answer.
None of us would say that we're overpaid, and you know, we appreciate the COLA when we get one from the state that only goes to OMH workers. We appreciate the COLAs that we get. Human services are really expensive, and I don't know if you can think of anything.
Reimbursement.
Okay, thanks.
Thank you, Katie. Christine Gorman.
Hi, Christine Gorman. I'm president of the West 55th Street Block Association. I'm echoing what has been said about the Be Heard and the mobile showers, and would like to help advocate for that if that turns out to be something that would be helpful. I also want to encourage the panelists, thank you all, to have more interaction. I know you're not fond of the NYPD, but one thing they do really well at the community level is they have monthly meetings where community folks can come up and bring issues. And I think if Be Heard and others were part of those community meetings, you would find a lot of folks from the community would be on your side and actually do want to help. I know you talked about fear of mental illness. I've lived in New York for, I don't know, decades. I am not afraid of mental illness. I think a lot of, I see homeless people. I know which homeless people are in our neighborhood regularly. I know many by name. What I fear is that tiny percentage who maybe dual addiction, dual diagnosis, mental health issue, and addiction, who randomly strike people, like what happened in front of Gristides on Monday, March 27th at 3 p.m. when a woman was beaten for no reason about the face. Fortunately, the crowd around subdued the gentleman who attacked her. Police came and all of that. And he's
Christine, I
system.
think your time went off. So,
but I'm just saying, sorry about that. People are afraid when violence happens, and it does happen on the street.
Do you know how to connect with NYPD about these monthly meetings?
I do know how to connect with NYPD about monthly meetings, and that's why I'm saying I think social services folks should connect with them as well.
I will say that from IMTs, and we have tried to do that before. We have initiated conversations with our local precinct. We have discussed things with them before. So we are working towards that. We are working towards getting them to like understand our clientele and the people that we work with. And they have been helpful when we have connected with them.
What I'm saying is show up at the community council meetings where the community is, so the community know. This is the first I've heard of Be Heard. It would be great if Be Heard, we can help advocate to bring Be Heard to our various precincts.
yes, that's true. Next, Charles, disability.
Can you hear me?
Yes.
You can hear me. Oh, okay. Hi. So I'm worried about aftercare for people with mental health issues and who have been formerly homeless, because I'm in a building that houses people who have mental health issues and who are formerly homeless, where CCS works out of. And for months now, I haven't had, some of my fellow tenants haven't had a CCS caseworker for a very long time. And when we do get one, they come and go. So we're talking about trust here, but it's really hard to form trust when, your worker who you form a trust with leaves after, a few weeks or a few months. I'm also concerned in my building where CCS works from, medication is not being allowed to be delivered to the tenants to their apartments anymore. In fact, they have to go down to the security desk instead. And also their packages, their personal packages and things like that are not allowed to be picked up on the weekends. We have a security firm in our building.
Excuse me, Charles,
Oh,
you
sorry.
have less than 25
Thank you.
seconds.
Sorry, I apologize. We have a security firm called Ally Barton who are very rude and disrespectful to the tenants, and I think they need to have sensitivity training. Also, as a blind person, I would like to know, why is it that CCS staff members are not allowed to guide me to the events in the building where I live? So I'm excluded from participating in events that are put on by CCS in the building. Thank you very much.
Okay, thank you, Charles. Alita Diaz. If I pronounced your name incorrectly, please let me know. Did I not bring you over?
No, you haven't.
Okay, she's coming over right now.
And also you could do that with, I guess, Pete and Emma.
Yeah, I will do Pete Davies and then Emma Smith next.
And Arlene.
Thank you.
Arlene Guy.
All right, we can start the clock. Alita, are you here? All right, going once, going twice. All right, we're moving on to the next person. I don't remember who it was. Pete Davies, I believe.
Hi, thank you very much for all the good information. I had typed a question into the chat, but when I switched over to attendee, it disappeared. So my question is this: have the previous, considering the funding that was mentioned by our state and city elected representatives that is being allocated, has the previous program, specifically Thrive from New York City Mental Health, been analyzed to understand what didn't work, and if so, what was learned for upcoming funding to make sure that our resources are well spent? Thank you very much.
Pete, that's a good question. We don't have anyone here tonight from DOHMH or from the mayor's office. I don't know if Ellen or Dr. Yu, if you feel qualified to address that. My understanding is that there have been all kinds of changes made to it, but I really cannot profess to be an expert at it. But if you have that question, I think that what we should do is take that question and see if we can get an answer for you on it. I know that it has morphed.
Thank you, Susanna. I'm having trouble saying your first name, Ms. Diaz. How do you pronounce it? Thank you. Aleida Diaz.
Yes, thank you so much. I just want to say thank you quickly to everyone, but especially to Cases, who has been very instrumental in helping us with a present problem. All your ideas are great, but I just want to put this out there. What would you say in a real-time situation to a mother who's had her adult son in the last 4 weeks hospitalized 5 times and released? He is psychotic, he's dangerous, not just to himself, but he's assaulted several people in our community. And unfortunately, the hospitals, you know, it's like a revolving door. He goes in, he comes back out. He's not on a treatment plan because he cannot administer medication to himself. He starts and then he stops. So my question is, what do we do about this present situation? The short-term plan is great, but right now we have not just homeless people, but homeless people with mental issues. This young man who in his right state of mind is meek and gentle and kind, but he's being labeled by the hospitals as being hostile, and that is really not a mental problem. How do we get
I'm going to jump in and ask maybe Dr. Tabor, maybe you can answer.
It's not a short answer, but there's something called a mental hygiene warrant that a family member can go to.
May I interrupt you for 1 minute? We have that, and they did not pick him up. We also have an AOT order that wasn't able to be applied because NYU did not admit him or send him to a hospital with a bed. There's a long waiting list for community referral.
I have an idea. This sounds like an issue that maybe we can talk more about behind the scenes. Maybe you need to be connected with someone here who's on the panel to discuss it more. But I think it's relevant because this gentleman, he's not the only one who's in this kind of situation.
Exactly.
But I was wondering if maybe Dr. Tabor, if you can give a short answer, or Dr. Yu, if either of you can give a brief answer.
The short answer was what she already said didn't work. So now we're down to long answers. Unless, I don't know if Vanny, you have anything that you know that.
Because I was thinking one of the same things that she already said too.
I think it partly, this is not an answer, it partly reflects the hospital capacity issue that was mentioned by the electeds earlier. When there's not, if the capacity goes up, more people will be admitted. It's sort of a kind of a numbers game. But I'm surprised if there's an AOT order, as I think Ellen is, if there's already an AOT order, that hasn't been helpful, because it typically is. And I mean, I think the only thing I can think of is to call the AOT office directly, if that hasn't.
We have dealt with Dr. Salloway.
I'm gonna jump in. Ms. Diaz, what CB do you live in?
We're in Kids Bay.
In Kids Bay?
I'm
Mhm.
gonna
Yeah,
put,
we're happy to talk to her outside of this, to figure
Thank
that
you, I
out.
appreciate
but
it.
how are we gonna connect you?
Brianna, can you put your information? Do you mind putting your information in the chat? Your email?
Sure.
Aleda,
Professional email.
Aleda, if you can see the chat,
I
you'll have.
can just do it. I'll do it.
But Ms. Diaz, thank you very much for raising that. It's the kind of,
Send me an email. When I did my residency in Massachusetts, and I got calls from Senator Kennedy's office all the time, and you may have to go that route.
Thank you, both of you. Brianna and Dr. Tabor. I promoted Smith. Your last name is Smith, Emma Smith.
Hi, yes, good evening all. I'll be so quick. I know we're at the 8:30 mark. Thanks so much for all your insights.
You get
and
10 seconds
on this.
No.
Yeah, exactly. I think a theme that a number of you panelists mentioned in separate ways is kind of this a lack of integration with the neighborhood at large, right? Folks feel alienated. I think folks recognize that people are, quote, frightened of them. That feels like a real sadness. And I can't imagine makes it easy to ask for help and get services and even utilize things like a mobile shower van, et cetera, right? There is so much stigma there. And Abigail, that's something that you mentioned in like changing the perception. I'm curious if you think there are any like distinct, I guess, awareness type campaigns or education type campaigns that would be helpful for community members, just in understanding some of what you shared, which is like, folks see this, folks have a lot of shame around this, folks aren't dangerous. This is what you can do in the case of some sort of, I guess, what do you think about?
Thank you, Emma, for your question. We got it.
Yeah, there is actually a training that is more so oriented towards just the everyday citizen. I believe it's called the mental health first aid training. A lot of churches have implemented this. A lot of just like community centers have implemented these types of trainings. I think like traditionally they haven't been accessible to the general public as easily as it would, as we would like. But I think, yeah, offering those and promoting those to just the general public, not just people in this field, would be hugely helpful. I know that a lot of people were also offering it to barbers shops, places where our population does frequent, things like that. That would help a lot.
That's a good idea. Thank you, Abby. Susanna, did you say something?
no, I didn't. I just am seeing that Arlene Gaeta and Alexandra Savinskaya and Loyal Miles was on, but he seems to have lowered his hand now. He's with cases.
Given the time, it is 8:32. I just want to be mindful of the time and ask our four panelists who are here, do you have time to stay on for, let's say, another 10 minutes?
I don't have
Dr. Yu.
I have a kid to feed, so I'm sorry.
Thank you for coming and for giving your time. I really appreciate it.
Yeah, thanks for having me. Thanks for having me. I appreciate it.
If all of you need to leave, that's fine. We'll thank you and we'll take additional input from the community and we'll hold on to it.
One thing somebody asked about education, if there's a transcript of this is a great beginning. I mean, this is, I think, the exact kind of activity that the community, this community and probably everywhere, really wants to be able to talk about their frustrations, what affects them. And then, some of us who have a little experience can talk with you. I would come back, I'd like to be done for now. It's been, but I would be happy to come back, or somebody else from ICL would be happy to do this, and we can do this, around the city. I don't know how much communication the community boards have with the other community boards. Looks like there's a whole bunch here, in other boroughs. I think this is a really valuable community building exercise, and it helps demystify some of the problems that we have. So
absolutely, thank you so much,
very
Dr.
much for the
Tabor.
invitation and the opportunity.
Abby and Brianna.
Thank you guys so much. We're going to release all of you and we'll continue to talk with the public. We really are grateful for your time and for your expertise, for the work that you do every day. And we promise to pay you back with a very thorough report.
All right. Thank you. Thank you all so much for being here.
Thank you.
Thanks all.
And I see 3 more hands raised, right?
Right. So we're going to recognize the 3 hands that we see raised. I do see, Michael, I see your hand, but we are going to allow the 3 people who did not get to speak this evening, and then we're going to move on. Arlene, I'm going to move you over, and then Alexandra, and then Loyal Miles.
If it's 10 minutes, I can stay for 10 minutes if that would be helpful.
Yeah, fine.
Let's see what kind of questions we get.
Yes, whatever you are willing to do. Arlene. You are on mute, Arlene. Thank you. Oh.
You're still muted.
We're going to go on to Loyal Miles. And
Okay.
Then...
All right. I'm unmuted now. I'll make it very quick.
Oh, okay. Thank you. Thank you.
Like Emma, I wanted to know what, as a private citizen, I can do to try. There are a lot of good suggestions, like getting Be Heard down in Lower Manhattan, more outreach. What, as a private citizen, can I do to help implement this, or who can I contact to do that? And also, there is a homeless outreach center on 14th Street between 6th and 7th. It's got a very low presence, and I was surprised that it didn't have any signage, but apparently they want to keep it low key. I believe it's doing a lot of the things that it's providing, a lot of the services that have been talked about. Is there any more of those in the works? Because it seems like it's a successful way to allow people to shower, do their laundry, a lot of the things we've spoken about already today.
Thank you for mentioning Paul's Place, which is the first safe haven and drop-in center to open in CB2. It is, as you say, it has a low profile, but it has a lot of clients. It's been very popular. And yes, I think that the city is well aware that we need more safe havens and drop-in centers. They take a lot of time to bring online. Paul's Place took 4 years, 3 years. But yes, those are definitely on the wish list. Thank you. Thank you for raising that.
I actually called Alexandra next and then Loyal. I apologize.
Hello, I'm Alexandra Savinska. I'm Hunter College student, and I'm very grateful to have this opportunity to speak today. So something that can be implemented as a short-term solution are free hygiene kits that include toothpaste, toothbrush, underwear, napkins, feminine hygiene products, and it can be given to all homeless people to build connection and provide help. Those kits can have a little flyer with information about mental health problems in their neighborhood. Mental health programs in their neighborhood, and a free Metro card, so they can travel to the location if necessary. We don't need extreme findings or trained people to do this kind of job, but it will help to reduce the pressure between the public and the homeless population, because homeless people will have an opportunity to take a better care of their hygiene, and people from the public will see that it is safe to interact with homeless populations because we have these workers who are giving the health kits. And in general,
Alexandra, you have less than 30 seconds.
Okay, thank you. And in general, when it comes to people with mental health problems, they are not dangerous when they feel that they are safe and that they're in a safe environment. Thank you for listening to me.
Thank you. And Loyal Miles.
Hi, everyone. I work at Cases, so I just want to be upfront about that with Abby and Brianna, and want to thank them for after their very long days, and also to Dr. Tabor and Dr. Yu. I want to thank the committee and the community boards that are really engaged around this issue. But I do want to raise a note. I actually lowered my hand because I was the last voice. But I think there's some concerns about Be Heard, and I shared in the chat a report, and I just want to. I think it's a really good idea, and that model is working in some cities around the country. But I do just want to note that it has not been, the data is very mixed in how it's been implemented here in New York. So if that is part of the resolution that you all are considering, I would include some things about how you want it to be implemented, because I think there are real questions, not just about its reach, but also about dispatchers making choices about if there's any imminent risk. It's actually in the job descriptions. Be Heard is not dispatched. which leads to the kind of criminalization of mental illness that is not a solution. People end up back on the streets, back in your communities. And I think I would make a push for the kind of long-term solutions that IMT and ACT represent. There's a long waiting list, as Brianna mentioned, for IMT. Cases operates forensic ACT teams, which serve people who are involved in the criminal legal system. There's a really long waiting list for those programs also. And those programs can be launched fairly quickly. Relationship building takes time, as Abby shared, but the data is very positive around these models, especially the ACT models, which are the basis of the IMT models, working to help people achieve recovery. And someone like was described, the son who was described, that's exactly why these services have to last a long time. And the engagement keeps going. I thought Dr. Tabor said it very well in comparing it to diabetes. So anyway, I really appreciate you all doing this, but I just want to make that note of caution. If you're advocating for Be Heard as part of this resolution, I would recommend someone has to the person has to be connected with a service. And that means something like IMT or ACT, I think, in terms of what we know works.
IMT or ACT, okay. Okay, thank you. And we have no more hands up at this time. Susanna?
Well, I was going to say that this concludes our public session. Thank you very much to all the people who work in this field and who gave your time tonight to us. Thanks to all the people from the public who sat through this meeting and waited their turn and asked questions that inform us and help us. We're now going to go into business session. And what that means is that because it's a month, we'll release everybody. And if everyone would like, you're welcome to stay and listen to us, but we don't take public input and we will absolutely not look at the chat. Community boards 2 and 5, our committees have to produce, we'll be producing a resolution out of this meeting. So we need to have a little powwow after this public session where we decide what to do. So good night, everybody. Everyone from CB2's Human Services Committee, stick around. Same with CB5. To the members of the public, good night. Thank you so much. Yes. I guess
Susanna, Vanessa Jones Hall, is she from CB5 or 2?
I don't know her.
She's from the police department's community affairs department. She works directly.
I think that's an important conversation, but maybe not for tonight at this hour. But is she have her hand raised? Oh yeah, well.
Yeah, she does.
Yeah, let's hear from her then.
If you could just make it as brief as possible, Vanessa, please, and thank you. Is she here?
Well, I can't elevate her. Oh, here she is.
Oh, okay.
You're muted. Vanessa, are you able to unmute yourself? There you are. No.
Hello?
Okay.
Well, I'm sorry, I thought I had my hand raised earlier. Thank you for allowing me just a couple of minutes or a minute. My name is Vanessa Jones Hall. I'm the community ambassador for Manhattan South of the NYPD. And I just want to thank you for all of what you're doing, but we are also.
And can you remind people where Manhattan South is?
Manhattan
what
South,
it covers?
It covers from the South Street Seaport all the way to just 59th Street and Columbus Circle. I covered that entire section. And also what we're doing is the ambassadors program. We have now, with the new chief of patrol, Chief John Shell, has made us a quality of life unit. And the quality of life unit, what we're doing is that we're preparing to work with all the agencies and have an interagency meeting so we can see how we can come together with some type of resolution to combat the concerns that's going on in our community. And a lot of things that when I go out and speak to you all is mainly about the homeless. I heard about Paul's Place, and I also was told that by one person that when Paul Place came about, that they've seen a lot of influx of homeless in their community. So we're trying to see how we can all work together and being able to come together and show what is going on in our communities and how we can work together. And like you said, funding. But what I really would like, I put my-
We have about 20 seconds.
I put my email and information in the chat, and I would love to receive all of your information. So once this meeting is ready for Manhattan South, that I'll be able to contact you all. Thank you for allowing me the opportunity to speak.
Thank you so much for being here.
Thank you for coming. Okay, now we'll go into executive session, right? Business session.
Yep.
So we'll start with CB2.
Does that mean I can shut?
You can go bye-bye and have a cocktail now. All right, guys. So I wanted just to get some broad strokes tonight and sort of vote on broad strokes, and then we'll tighten up a resolution. Tell me what you've heard. And I guess we'll raise hands, but I wish we were all in the same room. I can't call on people for some reason that I don't understand.
So Susanna, can I just mention a few things that I starred that folks talked about, the panelists talked about?
Yeah.
So first off, they talked about the importance of a room of their own, so SROs. They talked about providing shower and clothing rooms, perhaps even in a mobile unit. They talked about providing Suboxone treatment and Narcan to folks that are working out in the community. They spoke about, I thought, hygiene kits that included a Metro card. And
I'll add to your list. I'll add to
and then be heard. Okay, I'm done.
I think that we should all add to this list. I've heard ACT teams and IMT teams and sufficient funding for them, and also perhaps even inventive thinking about staffing to sort of meet the staffing challenges.
And by the way, bachelor's level in New York State can be a social worker. There are two different levels of social worker. There are the ones with a bachelor's degree, and those are dependent. That means they need a supervisor. And then there are master's level social workers, which can be independent, and they do not need a supervisor. Community case manager, and then the community case managers, ideally they need a bachelor's degree or 3 years work experience, I believe.
What we heard from, we did speak to someone at DOHMH, and she sort of ran down what the IMT teams are made of, and it includes like a bachelor level plus a master's level. And what I've heard is that it's a staffing challenge no matter what, right? So one is increasing budget, and the other thing may be having to find some sort of flexibility or innovative approaches to it. I mean, Ellen Tabor talked about how listen, if you're going to be administering medicine, you can't just do that with a college education. But she also talked about the possibility of using certain parts of teams for certain things. So
you can leverage the psychiatrists who have to provide the psych eval and medication management. And so they can be leveraged for short appointments, short visits, through the use of therapists and other health professionals or healthcare workers. And I think that's what goes into the ACT team.
Who else has comments? Keen? I can't call on anyone for some reason. I'm not a host. I don't know why, but Renee.
You just called on me and you said my name. That's enough.
Okay, go ahead.
If you need me to do anything, Suzanne or Renee,
No, I'm
let
good.
me know. I have access.
No, we're good. Everyone's a panelist. I'm just being a dope.
You're a co-host now, by the way.
It does seem to me that the most important thing we ought to work on is getting more people to do this work, and that there are 3 ways to do it. One of them is I think this raising the salary idea is important. I think getting rid of some of the credentialing paperwork stuff that does not really meet the need is important. And I think getting the pipeline, scholarships for anybody who's getting a degree and needs to pay off a loan who is working in this field. Those are 3 things that I think we ought to advocate.
Right. Ivy?
So I was thinking a lot about the situations we had in the last couple of years. Can you hear me?
Yeah, I don't know what that was.
No, I heard somebody else. Like Chinatown was awarded some large funding during the pandemic. I don't know if we can have conversations with the community, like how's that going, whether there's some budgets that we can put in place and use like senior centers at night, which already have bathrooms. I think there's showers. If there's not, install them. There's also the issue of laundry as well, whether like the community can book a day that's, I don't know, whatever the slowest day and have a couple of hours where people do laundry, and with that kind of budget that's there. Because I have a feeling that the money that Chinatown did is not dispersed because they can't make those connections. And I think we need to, and that's, I've talked to our working group a lot about getting back to the community, because that really is what is necessary to move forward together.
Yeah, that's a great point. Do you have any sense of how that would go into a resolution? Like what would we be calling upon local community?
Well, yeah, I was in the resolution. I think that we should open up the conversation by asking, what is it called, the Chinese Planning Council, who received that money.
Okay.
Just like give us a sense of like how's that been used and what is left, and we need A, B, and C. Can that money be put in this? Can we try it out? Can they figure out a way to contract expertise to do it? That would be something I put on the table.
Wayne?
I just heard a lot, or at least from the doctor, funding for additional positions, not additional outreach teams.
Right. Yeah, I think also he confused when he said outreach. He was talking about the Manhattan Outreach Consortium, which we're familiar with. So that's a DHS program, a Department of Homeland Security. So I hear what you're saying. Funding for basically funding for ACT and IMT, as opposed to more not more MOC, Manhattan Outreach Coalition Consortium. Yes. Mary Brosnan, CB5.
Thanks. I just wanted to point out that the outcomes long-term for both ACT teams and intensive mobile treatment are entirely dependent on access to housing. And so while I really appreciate and agree with Ivy's comments about student loan repayment, I think that would be a tremendous help. I would lean towards focusing on the showers and the laundry, as well as the Be Heard. I've followed Be Heard since its inception with community access. I do think there's an issue with the dispatchers, but the model itself is very strong. And I think that it would do us well to have more of that in our community boards.
That sounds great. Is there anyone else? I mean, we might as well have a conversation.
Brianna, can I just add one thing to that? There's a federal loan program that reimburses social workers, nurses, doctors. If they work for a mental health, a nonprofit, they can have their student loans reimbursed. And I don't know what the threshold is, but I think it's quite a high amount, and I can get that to you in the next 24 hours.
That would be interesting. We also heard something, it's DOHMH, I think they were talking about, were they talking about getting H&H to, there was something about H&H, right, Renee, that they were going to forgive loans if people came for H&H, Health and Hospitals.
Yeah.
Is there anyone else on Community Board 2's committee who wants to, or anyone here on any tile on this screen who would like to say anything? Okay, what do you think about a resolution that if we write a resolution in support of the advocating for the kinds of things that we've heard tonight, are people in favor of that?
Yes.
Yes. Okay. So what
Mary's Mary, oh, you just put your hand down again. Sorry. I saw her hand. Mary?
Yeah, should we call on her? Oh, but right, Mary, is your hand still, do you want to speak again?
Yeah,
or-
I just don't, I have to say, I ran the Coalition for the Homeless for 30 years. I've spent most of my adult life working with homeless people. I cannot get behind a resolution, which is to expand ACT and intensive mobile treatment. It's a bottleneck. We need more housing. And I think if we're looking for something that is short-term and is going to be effective, again, I would have to stress the be heard, the laundry and shower approach.
So are you saying that you think that ACT and IMT are not good services?
Yeah, I'm saying that putting more money into that, I would disagree strongly with what the doctor said. This is not a communication issue. The programs that have access to housing are far more effective. They have much higher outcomes. And so, you know, even just the DA tossing $9 million, like we need another chef in the kitchen doing outreach, that's not what's needed. I don't think it's about outreach. I think it's about getting people real services. And otherwise you're going to wind up in situations where these services are mandated, and that's not a good situation. I think last year, or maybe 2 years ago, Renee, we had folks from Housing Works and Community Access echoing that approach.
I think the thing, but Mary, the thing is, I mean, I think everyone tonight has said that there's a certain, you know, the buck stops at housing. Like there's only so much you can do without housing, right? Thankfully, city and state agree with that. And they seem to be promising a lot of money to that. What we're trying to push just in this resolution is other things, assuming and reiterating the need for additional housing. What kinds of things can we be doing in addition to that, not instead of that, in addition to that, that can be implemented quickly? Because I mean, I'll tell you, housing, we were gonna, housing, Paul's Place, which is a safe haven of 24 beds, took 4 years to get online. It takes a long time.
We could have a more deeper conversation about this, but there are scattered site approaches that do not require capital. We could also ask that we go back to funding more hotel rooms. Getting somebody to leave the street and go into a hotel room is going to have a far higher percentage of a positive outcome than directing them to go to Bellevue Men's Shelter.
Mm-hmm. Okay.
So I want to circle back, so I had said tapping into maybe money resources funding that is in the planning council for the Chinese planning council in terms of like neighborhood money that's there. The senior centers, for example, they close around 5 o'clock, and there's all that space there to shower, sit down, encounter all the assisting that they need. I mean, this is stuff that we have right now that is not utilized. So I want to circle back to whether, we could contract laundries from 6 till midnight or midnight to 1 and have like a pipeline. That is achievable, I think.
So what I'm hearing you say is using the bricks and mortar that exist and creating programs that leverage those to provide temporary respite beds, basically, for people who need them. Actually, Jody Rudin, we had a conversation with her. She is the head of ICL, where Ellen Tabor works, and she said, there's a shelter on 11th Street. It hasn't happened. It hasn't opened yet. They're working on it. Stick some beds in there. Let people sleep there. So I think that's what I'm hearing you say, is to find innovative ways to use the existing infrastructure and program it so that it could be used to provide beds.
Yeah, my senior center across the street has 5 floors.
Maria has her hand up. Sorry.
What?
Yeah.
Maria, what do you got to say?
Just because I feel passionate about this, I want to piggyback off of what Mary actually said. I think she is right. And when we're talking about like long-term solutions, stability for people who have serious mental illness and chronic mental health issues, stability and that is most effective. I do believe that being unsheltered, living on the streets, is not sufficient. That is considered a basic need, right? There's basic needs: food, clothing, shelter. And if you don't have those, it impacts your emotional and mental well-being. I entirely agree. And we talk about this on CB4, actually. And I'm just going to give a little plug. One of the things that we're actually talking about with, I believe it's EDC, is actually Bayview. That'll be supportive housing and a more intense level of care for people with SMI. But the goal of tonight and writing this resolution is thinking about short-term, like short timeline solutions. So what that looks like in my mind, even though I think there's value in everything that we've heard tonight, for example, the kits, to me, that makes a lot of sense. When Dr. Yu's talking about the coffee cups, the kits is going to be something similar. When you're talking about building rapport, when you're talking about giving people clothing, having them take showers, those things matter. I think specifically though, if we're going to hone in on something that is going to be a short timeline, let's say approximately 1 year, what makes sense is something that's already currently in place and effective, right? And one of the things that kept coming up is actually ACT and IMT, but what we heard a lot also was about salary. And to me, in my mind, besides permanent housing or even safe havens and drop-in centers, what makes most sense is treatment. And so I'm kind of hoping that people can be thinking about that a little bit more and, share your thoughts about what you agreed with most from what you heard with the panel, and not just like the mobile showers or the kits. That's not helping someone long-term. We can put something in place that's short, get it rolling, or something that already exists, get it rolling, but there's long-term consequences and outcomes from it.
Because one thing that I, as a layperson, imagine is, if you have mental illness, you need to be on medicine, and someone has to help you stay on medicine. So you have to have a place to live. But even if you have a place to live, you need someone to be engaged with to help you stay and take your medicine. Rachel?
I think it's really not an either or, but I absolutely agree with Mary that there's no point in increasing the amount of therapy and treatment if they're for homeless people who have no option of place to be stable in. I mean, you've got to get some. I agree. I would pay more. I'd be more willing to support hotel rooms and getting people into some kind of a place where they can live. And I'm very much in favor of paying people giving treatment more. I'm in favor of getting more people into offering treatment and making sure they have better working conditions. But that would be secondary to the housing. And I agree with using everything that's already built, that's already out there, the hotels. What about the 4 billion empty office buildings out there that nobody's going to work in anymore? Is there any way we can leverage any of that?
I'm sure that all that's on the table, but
Can I just say, I mean, we get that. We really, really, really hear you. Supportive housing, that was #1 on our list. When we came to this, that's what we thought, and we get it. I just wonder, and I don't know, I'm not an expert, but to stabilize people, to get them okay in the very short term. Are kits and our hygiene kits and showers better than the outreach? Is it a zero-sum game? I'm wondering.
Also, you're not talking about outreach, right? We're using that term a lot, but outreach,
not outreach, treatment.
Community, right.
Treatment in the field is what it is.
Sort of community
You know,
treatment.
the one thing that we did not talk about with respect to housing, that is something that's used in other places, are group homes.
Mm-hmm.
So where there are a group of people with serious mental health issues living with somebody who does not have that, and it's a group home.
Yeah, I mean, I think we all would agree that, there's only so much you can do if you don't have a place to live. Although having witnessed the difficulties that 3 shelters have had trying to get online in CB2, I'd like to see something that also addresses people tomorrow, that helps people tomorrow. And it makes me upset that there are waiting lists for these programs, like for IMT and ACT, there are long waiting lists. And so, you know, like that woman said, like, what are you supposed to do? Mary?
Thanks. Again, we saw the capacity of the city to ramp up fairly quickly with the hotel rooms. And again, I look to the people on the front lines at Housing Works and Community Access. They come back again and say, if I can offer somebody a room with the door that closes where they feel secure, we can provide the wraparound services. And so, you know, I don't think it's an either or thing. I'm trying to sort of be responsive to the construct that you guys have put in place for this evening. So, you know, if what the mandate is tonight is to come up with something short term, again, I'm going to return to, you know, it's the hotel rooms. I wish I could drop in, maybe Renee, you could drop into the chat the article from the New York Times about the mobile showers, and certainly the laundry. That was a revelation to me, Ivy. People want to have a place where they can clean up, and that these are all attachment vehicles for getting people to accept treatment. And I think that's where I would hope our energy would be.
Thank you. Thank you. I appreciate that. Is there anybody else? Oh, Ivy, sorry.
So Susanna, I know like the thing that keeps on coming back about, like, you know, all this office spaces. Is there any way we can put in as a resolution? Is like, I know that's the longer term situation, but the community keeps on bringing it up, whether we can ask somebody in a resolution is like, is this being studied? Is there like what are the steps of, I'm sure people are looking at this stuff. It's not like,
yeah, no, I think that they definitely are, but
right.
I take your point, which is, I think that we can certainly affirm our support for some of the stuff that we know is going on.
Right. So basically we want to connect with the people that are thinking and they're acting upon it, whether it's successful or not. At least like we're not just saying in the ether, like we would like this. Is there anybody?
No, that's why we were trying to focus this on, you know, like what can council walk in tomorrow and say, let's do this? Because I mean, for example, to Rachel's point, yeah, there's a million empty office things and people are talking a lot about what we can do with that office space. It's not so easy to transfer it to housing, blah, 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 blah. But that's an interesting.
Yeah. So let's invite people that
happen tomorrow, right?
I know. So we can invite people that are, you know, can give us like an idea of what kind of movement that's happening. So getting back to the shower, the other thing I was thinking that I think is completely possible is that if within the money that I think it exists within community already that is not being used, that besides the laundry, is that when people are showered, probably there could be a way to like shape where people that do hair can volunteer a couple of hours. And that is another source where other expertise can come and help out with the different things, whether it's mental health or the next night or what's the next food. But that could be possible. I mean, there's tons of people that, you know, a lot of the salons have like teaching classes, certification. So there's people, you know, they need models or whatever, they need to apply that. So I think those are possible. Those are things that can happen quickly.
Yeah, can I just quickly, I'm losing some of my CB5 members, and I would ask that they stick around because we need to do our business session.
Oh, you haven't done, this isn't your business session?
Well, I guess we're doing it together for the resolution.
Sorry.
But, okay, all right, we'll join in. But
No, I'm sorry, Renee, take it away. I'm so sorry. I just was folding it in because you said you didn't have quorum, so I just started like calling on your committee as well, but let's go.
Okay, let's go. Let's do it together. I just want to make sure that my committee gets the opportunity to ask any questions. They're still here. I think they've all left. Anyone from CB5 still here? Comments?
Oh, I'm so sorry. I assumed that I saw Mary's hand, so I assumed that everyone at CB5 was raising.
Sona, you're still here. Sona, can I?
Hey, I just wanted to like reiterate that I totally agree with Mary's point about the importance of housing access in the near term and the long term. I wonder if in the resolution, maybe there's one way for us to like explicitly state out that our long-term priority is housing, and then list out by priority our more near-term initiatives, like providing access to kids, to showers, and to all the other topics we discussed. But yeah, I just wanted to reiterate Mary's perspective.
Fabulous, thank you. Seth is
I
still,
liked that suggestion. Just saying.
yeah. Seth is still here, Rob's still here. I don't mean to call on you, but I'm glad you're still here, and I wonder if you have any input. Okay, yeah, all right.
I would just say I find that the housing thing is a perfectly good thing to say, but I think CB5 often bangs that drum, and I think it is a often ignored drum, and I think it would be valuable to focus on the more concrete, immediate term things that we came here tonight to look at. So I would be more in favor of burying that lead in favor of the stuff we've heard 2 hours of information about.
Thanks, Rob. Okay, Susanna, go ahead.
John Cedillo.
John, sorry, I didn't see that. John, I'm glad you're here.
Yeah, I just want to say, I think we're onto something with, mobile showers, laundry, it gets people in, it gets people feeling, like they matter. And, then we're able to build connections with them, build trust and whatnot. We complain about all these storefronts that we have throughout our communities. I mean, here CB5, we have them, CB4 has them. They're all over Midtown. Maybe some of those are those bigger spaces, these large buildings in the garment district where the ground floor is large. It's got a large plate, it's vacant. Maybe that's a good place for like the city to say, okay, well, we can rent this out, make it this facility for a couple of years. Some distressed landlord gets to say, oh, I got a tenant, and we get to say, we get these services that we need. And that gives us some time to actually build out the supportive housing that we need, throughout the city. But since this issue is mostly based here in Midtown, maybe it makes sense to start there and then while we build out. That's it.
Thanks, John. So what I'm hearing is you are in support of the smaller things like the showers, like the haircuts, like the hygiene, recognizing that we do need the housing, the supportive housing, and that, we should probably look to maybe conversions that are available right now.
I mean, I don't know that we'd be able to convert whole buildings and whatnot, but like to be able to say, okay, we can do something now, which is what we're actually here to do today, is trying to find something that's quick. Then the ground floor, storefronts, maybe that's the easiest way, for a short-term solution.
That's interesting. Thank you. Zona, do you still have your hand up? No. Susanna, go ahead.
Oh, I don't think Rachel, is your hand still up?
Yeah, I'd love to just add in what we've been hearing here. I mean, this is I think there's huge frustration to come up with ways to solve some of these problems. These are not fast solving problems. We've had these issues since the hospitals emptied out, the state hospitals emptied out 50 years ago. And they were supposed to lead to community group homes. Well, guess what? Nobody wanted a group home in their community, hence we don't have anything. And this is not this. I love the sense of urgency. And I think doing some of these things like the showers, like the laundry would be great. They're not going to solve the problem. And I think what I took really from Mary's, which I'm really grateful for, is that adding to treatment programs when they cannot succeed because they do not have a way to end up in housing is somewhat short-sighted. I mean, I'd rather put money into, I don't want to ignore that. I think there are problems there that we could add money to, but I also think that saying that we want to do something quickly is great, coming up with some things that might be nice, but the fact is until we can get community group homes and housing to replace the old huge mental health home places are not, we're not going to do it. It's not going to happen fast. We've been 50 years at this and nothing's happened. But let's do something acknowledging that it's not going to solve the problems. But I think we do have to keep on the plate what we're really looking at and what will solve the problem. So keep on the plate intermediate and long-term stuff.
Yeah, I agree with all those long-term strategies. But I have to say, like, when we started researching this, we talked to people who run a lot of different programs. And all the people that we talked to felt that IMT was the gold standard of treatment.
I'm not saying it isn't. I'm saying that it cannot end up, if you're working with clients who are homeless and you're doing a fabulous job of giving them treatment, eventually they're going to have to move into somewhere to live.
Yes.
Otherwise, it's not going to have accessible. That's what I took away from what Mary said. And that's what, that's the point.
Yeah. And not even from what Mary said. I think also, I mean, Mary has had her professional experience in it, but also the people who came to on our panel all basically said that too.
So it is a basic need and a basic law. And so it cannot, it does have to be some focus on that. I'm not taking away from any of the great treatment that's going on at all. But.
Great. I think Ivy, and then I think we can wrap it up.
So I have a middle point also to bring up. I know that today's we're trying to do the fast, like what we can do, and we're identifying that. The one thing that I've been circling for a while since the immigration thing has happened is I think, like, is there a way we can find a path of understanding how federal government can take those hotels that we as community had to take a long time to have like hearings about, if we're homeless, and suddenly, there seems to be two different paths. What I'm trying to say is, like, how do we have a little more clarity about being in discussions with city or federal about, since it takes us years to get hotel space now, how can we advocate to have clarity when we can have a percentage for the homeless that we need immediately, that we've been waiting for a long time, that now has been taken for another cause as well. And that seemed to have happened like really quickly. So I know we've invited people. I know they're two separate agencies and separate hierarchy. But I feel like that middle ground of conversation hasn't been clear to me as a citizen of, like, wow, that happened overnight and things take years. Where's a little bit more accommodation so that we can house people that have been on the streets for so long?
Can we just thanks, Ivy, that's interesting. I wonder if go ahead, Susanna. I didn't mean to cut you off.
I just that there's one or more person with their hand.
Yeah, Tristan, he's from my community board. Tristan, go ahead.
Hi, thank you. I'm not going to repeat what other people said. A lot of great ideas that I think we need to include, but I think we would be remiss not to just mention something about, some of the stuff going on at the state level with the budget, and even perhaps at the city level about providing financial support for conversions, because, obviously we're not going to solve that quickly, but that's one avenue that I think could help increase the housing supply.
Thanks. So you're talking about conversion from commercial?
Like from commercial, exactly.
Okay, thank you.
All
and
right.
even, the FAR cap, but I can understand if we don't want to go down that route.
It's a long, interesting plan. It's 9:17. I think that we are ready to wrap it up. I think that we have pretty much, I've heard a lot of ideas. I think I can incorporate all this into resolution. I'm hearing basically support for these initiatives in general, which I'm going to take as a unanimous vote unless we have problems once we see the nitty-gritty of the resolution. Renee, what do you want to say?
My committee has lost quorum, so we are not going to do a vote. But I think I'm going to regroup with our committee. I think our committee, with Mary and with some of the people on my committee, we have to put housing first and foremost, and recognizing that housing is important and those other things flow from that. So we can huddle on how we do this. again, I don't have quorum, so I can't vote on a resolution this evening.
Okay, gosh, what happened to me? All right, I'll work on a reso tomorrow. I'll have something drafted before the end of the weekend. We'll share it, and thanks everybody tonight.
Thank you, Susanna. That was a
Thank
lot.
you.
Thank you for doing it.
Everyone.
Thank you all.
Thanks for your.
Bye-bye.
Thank you.